All right. Hey there, everybody. So at the moment, just FYI, it looks like it's just me. So if I'm just kind of going through things speedily, it's because I am just talking to a recording right now rather than anybody here, but that might change. Maybe people will join. And just a reminder to people, I'll probably remind you of this at the end as well. So just a reminder that if you are keeping up with the recordings week to week, just make sure that you note that today is January 29th, week 4. We don't meet again until week 7, February 19th. So we'll have a few weeks off there. So, in case you're like, hey, where are the recordings? Just make sure you note the weeks that we meet. So after we finish up today, there should only be 3 recordings in there. And then the remaining 2 will be coming. Okay. All right. Well, since there's nobody here to ask any questions or anything like that, essentially we will dive in and pick up where we left off. And so this is the handout that we started last week on the cardiovascular system. We had gotten almost all the way through it, or at least part way through. We got down to here where it says blood. So that's where we'll pick up where we left off with last week. All right. So first off, when it comes to the blood, make sure you recall that all of the blood cells ultimately come from the red bone marrow. The red bone marrow, remember, primarily is found in the axial skeleton. So the red bone marrow cavities are in the bones of the sternum, the ribs, the vertebra, and then a little bit in the appendicular skeleton. We do have bone marrow cavities in the pelvic bones and also in the epiphysis of long bones, like these areas, the epiphysis of long bones. So that's where we're producing where we have active bone marrow that's actively producing blood cells. And remember, we have 3 categories of blood cells that we make. We make the erythrocytes, otherwise known as red blood cells. We scroll down, leukocytes, otherwise known as white blood cells, and then thrombocytes, otherwise known as platelets. So make sure you know them by both names because sometimes on the exam, they could refer to them by their more technical name rather than saying red blood cells, for example. So starting with erythrocytes or red blood cells, remember that the primary function, like what the red blood cells are doing for us, is they carry oxygen in the blood. Essentially, these are the cells that will transport oxygen in the blood. So they essentially determine our oxygen carrying capacity. How much blood we can circulate or how much oxygen we can circulate in any given period of time. And a little more specifically, you might remember that red blood cells have a molecule on them, many molecules, like 250 million of these molecules on any one red blood cell of hemoglobin. Hemoglobin is the actual molecule that the oxygen binds to on the red blood cell. And remember, you need iron to make hemoglobin. So iron is a critical ingredient when it comes to producing hemoglobin. So if somebody is deficient in iron, they won't be able to make adequate amounts of hemoglobin. And then ultimately that affects their oxygen carrying capacity. Remember that red blood cells are biconcave in shape. Sometimes you just get really straightforward questions like that literally say just something like, which of the following cells is described as being biconcave? Just a very general, straightforward question. You either know it or you don't. So red blood cells or erythrocytes are the cells that have that shape, meaning there's a depression on each side. And red blood cell production, remember, ultimately is controlled by the kidneys. The kidneys, you might recall, produce a hormone called erythropoietin. And erythropoietin is what stimulates the red bone marrow to make more red blood cells. Making more red blood cells is what we call erythropoiesis. And erythropoietin from the kidneys is what regulates that. So essentially, the kidneys are always monitoring the oxygen content of the blood. And if they detect that oxygen content in the blood is dropping, they'll release erythropoietin into the blood, and that'll stimulate the bone marrow to make more red blood cells. And that's what happens, for example, when you exercise. When you exercise and you put yourself into somewhat of an oxygen deficit because you're pushing your body and you're starting to burn through more of that oxygen, the kidneys essentially detect that drop in oxygen content And then they begin the process of stimulating more red blood cell production. And that's part of conditioning. That's how we over time get in better shape. We make more red blood cells. So therefore, we have a larger oxygen carrying capacity going forward. That's part of it. There's more to conditioning than just that one thing, but that is part of it. Now, as far as a few conditions go, we have iron deficiency anemia. And we already hinted at it. Basically, without adequate iron in the diet, or if the person can't absorb iron for whatever reason, we can't make adequate amounts of hemoglobin. And if we can't make adequate amounts of hemoglobin, our oxygen carrying capacity is going to decline, and therefore not enough oxygen to go around. And remember, we need oxygen to make ATP. So if we don't have enough oxygen to make adequate amounts of ATP, we're going to start to see some kind of compromised activity. So that could present in, fatigue. The person might have a pale look to them because oxygenated hemoglobin is what makes the blood red and does provide some coloring to our skin. So we might start to notice the person is paler than their normal pigmentation. They may feel cold because producing ATP creates heat as a byproduct. So if those processes are being compromised from low oxygen levels, then that would lead to maybe the person being cold in certain areas or cold generally. Sometimes they crave like odd quote unquote foods, like particularly kids, you might see them eating sand in a sandbox or something. The idea is that their body's craving minerals. I mean, specifically, they need iron, but they're sort of craving that minerally metallic taste because that's what the body needs. They'll be short of breath because, again, oxygen carrying capacity is compromised. The heart is trying to compensate by taking the oxygen you do have and circulating it more quickly, also pumping to the blood or pumping blood to the lungs more rapidly in order to reoxygenate it. So typically, all other things being equal, the heart rate would go up from their normal baseline. They'd have tachycardia. They might have dizziness, not enough oxygen to the brain. So a lot of signs and symptoms like that. And this anemia is often described as what they call a microcytic and hypochromic anemia. What that means is the red blood cells are too small. That's what microcytic means because they're underfilled. There's not adequate hemoglobin in them. So they're smaller than usual. And hypochromic, remember what we said before, it's oxygenated hemoglobin that gives red blood cells their red color. And therefore, blood as a whole, it's red color. So if there's lesser amounts of hemoglobin, if there's a lesser concentration of it, the red blood cells and the blood, even as a whole, might start to look more pale because of that. They call it hypochromic, less color. And again, these notes are already very narrowed down. So, like if I'm telling you things like this is a hypochromic anemia, that means things like that can come up. So everything here that we go over in the review class is already pretty narrowed down. So don't further narrow it down. If we give you some detail like that, do your best to, I mean, I know it's not realistic that everybody will remember everything, but do your best to try. Like don't purposefully just gloss over certain things. Then sickle cell anemia. This is a genetic defect. This is inherited via an autosomal recessive pattern. What that means is in order to develop sickle cell anemia, the person has to inherit a defective gene from each parent. They have to get one from each parent. If they only get a defective one from one parent, but they get a healthy gene from the other parent, then they'll just be a carrier. They won't actually have symptoms of sickle cell anemia. That's what we mean when we say it's a recessive pattern. It is more common in people of African descent, but that's not absolute. I mean, especially as people move to different parts of the world and, interact and form relationships with others. I mean, it's not absolute. The gene can spread into other communities, but it is more common in people of African descent. And basically, what this defect causes is it causes the red blood cell to become misshapen. Instead of the RBCs being that biconcave disc like shape, they're bent, they're curved. It's a sickle shape, like the Grim Reaper's got that staff with the I don't know what you call it, the blade that comes off of it. And that blade, it's That's the sickle shape. And so the red blood cells are shaped like that. So they're misshapen. They don't carry adequate amounts of oxygen because of that. So definitely not enough oxygen to go around. But also that misshapen quality leads to them becoming obstructed, becoming trapped in blood vessels. They can't fit through narrow blood vessels very effectively. So they become trapped and it leads to a lot of blockages, a lot of obstructions. So it cuts off blood flow to various areas. That leads to a lot of pain and cramping, because like muscles, for example, aren't getting enough blood flow. So they start cramping up, a lot of pain. Plus, of course, there could be tissue death as a result of that. And that can include like causing heart attacks, strokes. So that's really the big thing. It leads to a lot of stagnation. From a TCM point of view, we would think of it as it leads to a lot of stagnation. They also get priapism. Priapism is painful, sustained erection, and that's because of blood getting trapped in the penis, because again, the blood vessel obstructions. And then, of course, just like a lot of the usual anemia symptoms we already mentioned, like shortness of breath. I mean, all that stuff still applies. But blockages and pain, that's kind of the unique stuff that comes with sickle cell, more so than some of the other types. All right. Then we have vitamin B12 and folate deficiency anemia. These overlap, B12 and folate. So they're not the same thing. They are two different things. Like somebody could be B12 deficient and develop anemia. Separately, somebody could be folate deficient and develop anemia, or they could have both. But symptom wise, it basically results in the same problem when all is said and done. Both of those things, folate and vitamin B12, are really critical for cell division. So, cells where there's a lot of turnover, like red blood cells, those are the cells that really suffer from folate or B12 deficiency because there's so much cell division, so much turnover. Those cells are going to really be compromised when there's a deficiency in these nutrients that are necessary for cell division. So, in both cases, you get a situation where the red blood cells don't divide properly. Therefore, they're actually larger than they should be. They're what they call macrocytic. And again, this is a detail you should know. This is a macrocytic anemia. Normochromic, it doesn't affect the color because it's not a hemoglobin issue, but the cells don't divide properly. So they're a little too big. They're macrocytic. In the wrong size, that's going to affect the gas exchange. There's a reason that the red blood cells normally have that biconcave shape. It's considered the optimal shape for gas exchange. So here they're going to have, you want to know it's a macrocytic anemia. You want to know that, most of the symptoms we mentioned for iron deficiency anemia would still apply. But one standout is sometimes with these types of anemias, they get like kind of a red, swollen. Sometimes it's described as a beefy because it looks almost like a slab of beef, a beefy looking tongue. And one of the reasons for that is that that's not really the anemia itself causing that. It's more just like the cells of your oral mucosa also have a lot of turnover. So, like replacing those cells is compromised. And so it's like a thinning of the tissue, and therefore the tongue gets more easily irritated and inflamed and whatnot. Right. So that applies to both B12 and folate deficiency. And then lastly, there's what we call pernicious anemia. And that's a specific cause of vitamin B12 deficiency. Basically, this is a type of B12 deficiency where there's a deficiency in intrinsic factor. Remember that the parietal cells of the stomach make this substance called intrinsic factor. And intrinsic factor enables us to absorb vitamin B12. If we don't have intrinsic factor, then we can't absorb vitamin B12. And as we already mentioned, if we don't absorb that adequate vitamin B12, then that could lead to a type of anemia. So if this is due to lack of intrinsic factor, then we call it pernicious anemia. If it's just a dietary thing, like if it's just like, oh, they don't have enough B12 in their diet, and so we just change their diet and okay, now they're fine, then we would just call that B12 deficiency and we just correct the B12 deficiency. But if it's specifically due to a lack of intrinsic factor, then it's referred to as pernicious anemia. And most of the time, as you can see listed here, lack of intrinsic factor is often due to an autoimmune process that damages the parietal cells. There could be other reasons, like sometimes people have a genetic defect where they don't produce intrinsic factor. But most commonly, it's an autoimmune process that destroys the parietal cells. But when all is said and done, it creates B12 deficiency. We just give it a special name when it's intrinsic factor related. Now we do have a couple of people here. When I first started, it was just me talking to recordings. And now we do have a couple of people here. Anybody have any questions on anything? Either what you just came into or just any general questions you want to ask. All right. All right, so now let's go into the leukocytes, otherwise known as white blood cells. And remember, the big picture of leukocytes is they provide immunity, they provide immune protection, they attack pathogens, they clear out injured tissue, dead cells, they provide for immunity. And unlike red blood cells, where there's basically just one thing called red blood cells and they all do the same thing, they carry oxygen, there's different types of white blood cells and each of them has a different specialty. So you want to make sure that you're familiar with the different names for white blood cells and, which ones primarily do what. So neutrophils, and this will be very big picture on comp. So essentially what's here, you'll be fine. Neutrophils, you want to know they're the most abundant. So like something like 70% of your white blood cells at any given moment, if you got a test done, 70% of your white blood cells are neutrophils. And because there's so many of them, they're the first responders when there's an infection. They're the ones that show up on the scene first in relatively large numbers just because there's so many of them. And then ultimately they do battle. So they're like kind of like the warrior cells. They're going to do battle with the infectious material. A lot of neutrophils that die in the process. So they're really the warrior cells. A lot of them don't last very long. Like they might only last for a matter of hours. They get released from the bone marrow and then they go into battle and, they might die within hours of being formed. Eosinophils, on the other hand, are a little more narrow in purpose. Those are really two things cause those to be elevated. They're elevated in allergies and they're elevated when a person has parasites. Their specialty is binding to intestinal parasites like worms and secreting chemicals onto the worms that essentially digest the worms, break them down. But they are also elevated as a consequence of having allergies because eosinophils make chemicals that break down histamine. So if somebody has allergies, they typically have high levels of histamine being produced. So therefore, more eosinophils are made in order to produce the chemicals that break down the histamine. So eosinophils are typically elevated as a consequence of having allergies. They're not the cause of the allergies, but they are elevated as a consequence. So like as a general rule, like when it comes to labs, if somebody is said to have high neutrophil levels, you're typically just thinking acute infection. But if somebody has high eosinophil levels, now you're thinking maybe they have allergies, maybe they have parasites. And then of course, based on signs and symptoms and maybe other tests, you could figure out which they have. You could do, for example, a fecal test to test for parasitic larvae. And also like symptoms would often indicate if they have allergies, like, you know, do they have watery eyes and sneezing and, stuff like that. Then we have basophils. These are the cells that actually produce the histamine. So basophils produce histamine, and histamine, remember, is a major inflammatory mediator. It's a chemical that essentially stimulates the inflammatory process. Basophils make that. Then we've got macrophages. Those are the biggest of the white blood cells, hence macro in the name. They engage in what we call phagocytosis. That's where the phage comes from in the name macrophage. And remember, phagocytosis is where we engulf the foreign material. The cell membrane essentially involutes, they engulf the foreign material, and then they put it in little vesicles, release chemicals, and then break it down. And sometimes the macrophages are referred to as the cleanup crew because there's far fewer of them relative to the neutrophils. So they usually don't arrive until later, at least in large numbers. The neutrophils arrive in large numbers pretty quickly. The macrophages take more time to arrive in large numbers. So by the time the macrophages arrive, there's sort of already been a battle, and the macrophages are kind of cleaning up the debris, the dead cells, the any debris. Now, and they also do help fight the infection, but they're often cleaning up the debris and the remnants of the battle that already occurred. So that's why you might hear them described as the cleanup crew. And then the key thing about the lymphocytes, remember, which include your B and your T cells, the lymphocytes are going to orchestrate what we refer to as acquired or adaptive immunity. This is the more specific, precise immunity that's unique to individual pathogens or individual antigens, you can say. Everything prior to this, neutrophils, eosinophils, basophils, that's all kind of one size fits all. Remember, that's what we call innate immunity. It's one size fits all. There's a bacterial cell in the body. There's sort of just a generic way to deal with anything foreign. The lymphocytes, though, the B and the T cells, they develop a much more specific, precise immunity that's unique to every individual infection. They make unique antibodies. They develop unique receptors that react to those particular foreign antigens. So this is what we call the adaptive or acquired immunity. Mm-hmm. And the person doesn't have this in place until they get that first infection, but then it's in place from that point forward. So that's the reason that, for example, the first time you get exposed to, say, the chickenpox virus, let's take vaccines out of it. If, assuming no vaccines, the first time you get exposed to the chickenpox virus, you actually get the disorder, the symptoms, the condition known as chickenpox. Because the first time you're exposed, you only have innate immunity in place. And that's a little slower at dealing with the infection, a little slower, a little more, a little less efficient. But once you have had it that first time, and then you develop antibodies and all of that stuff, what we call acquired immunity, then those are in place for the next time you get exposed. And now you fight it off much more efficiently to the point where you might not even show symptoms. It depends on the condition. Like, every infection is different, but there are some things like chickenpox where, yeah, you get it once in your life and then never again, generally. And that's because you develop acquired immunity. And again, every infection is different. It's not always that efficient for every infection. Like, as we know, we can get COVID more than once. But usually the reason for that is because the COVID virus mutates a lot. So, like, the first time you got it, it was the initial variant, but then there's the Delta and the Omicron, and all those variants. And so your immune system has to adapt each time. Right. So remember that the lymphocytes that make up your acquired immunity, those are B cells and T cells. Remember that T cells, there's a couple categories. There's the T helper cells, and the T helper cells don't really fight pathogens directly. They're more regulatory. The T helper cells, the reason they're called helper cells is they secrete chemicals that essentially help activate other cells. So they help, they assist. they're not the direct warriors, but they secrete chemicals that stimulate other cells to go into battle. So they're an important part of the process, but they themselves aren't really the warrior. They're more like the manager. So they get called the helper cells. And remember what AIDS is, just to show the importance of the T helper cells. Remember that what AIDS is caused by the HIV virus infecting T helper cells and destroying those T helper cells. And then eventually the person gets to the point where they really can't fight off pathogens anymore. They're susceptible to all sorts of infections that otherwise would not really have been much of a problem. So that just goes to show how important the T helper cells are. That the loss of T helper cells is what causes AIDS. Now, of course, nowadays the medications are so good that somebody could have the HIV virus and never develop AIDS. But without the medications, I mean, that's what the virus was doing, back in the 80s when basically HIV was a death sentence. It destroyed T helper cells. And then eventually the person got to the point of no immunity, basically. Now, this acquired immunity here could be divided into two branches, what we call humoral immunity and cell mediated immunity. Humoral immunity is basically what the B cells do. When the B cells are exposed to a pathogen, they make antibodies. Another term for antibodies is immunoglobulins. Make sure you know that those mean the same thing, because on the tests, they could use either term. And antibodies or immunoglobulins are specialized proteins that have a special shape that they bind to whatever antigen they were designed to bind to. And that ends up basically surrounding the foreign cell, neutralizing it. It damages the membrane of the foreign cell, if it's a bacterial cell. And then that sort of puts a target on its back for things like macrophages and neutrophils to come gobble it up. So that part, what the B cells do, we call humoral immunity. That involves antibodies. And then the other type of T cell, what we call T killer cells, which are also known as cytotoxic T cells. Again, make sure you know both names because on the test, they could use either term, either expression. T killer cells or cytotoxic T cells, their job is to find diseased body cells, like cells of the body that are infected with a virus, for example, like if hepatitis B infects liver cells or cancer cells. Their job is to find diseased body cells and destroy them so the cells don't replicate and turn into, additional diseased body cells. Well, that's basically the job of the T killer cells, also known as cytotoxic T cells. And then lastly, thrombocytes, also known as platelets. Remember, they initiate coagulation. They initiate a coagulation cascade to stop bleeding. Or another way of saying that is they initiate clotting. Remember, it's not just the platelets that do that. Remember, there's also 13 clotting factors that get activated by the platelets. And all of that needs to work to form a blood clot. But the platelets are a key part of initiating that cascade. And ultimately, if somebody cuts a blood vessel, that's what begins the process of starting the clotting. All right. Any questions on that handout from the people that are here?
Do we need to know the 13 cloud factors?
Like the names of them?
Uh, maybe, yeah, or maybe
No,
very special. Okay.
no. If you needed to know the names of the 13 clotting factors, I would include it in the notes. So
Okay.
yeah, if I'm not including it in the notes, then it probably means you don't need to know the names. If I'm not going into that in the review class, then it means not to worry too much about that.
Good. Thank you.
Yep. All right. So now let's jump to a little auricular here. So remember, we had said in the acupuncture section of the comps there that most of the acupuncture section is just a repeat of what you already did for first year comps. I would say about 75% of it, about 45 out of 60 questions, just the same stuff as first year. Point locations, point categories, soon measurements, point functions, all that stuff that I reminded you of the first day of class, of the review class. Then the additional 15 questions are from the extraordinary vessels. So the things like the yin chow, the yang chow that we went over last time, and auricular from your auricular class. That's probably the remaining 15 or so questions. Now, auricular obviously can get really complicated. There's a lot of ear points and a lot in a small area. The good news for comps, though, you don't have to do any auricular practical. So for comps, you don't have to actually worry about like nitpicky differences, like where you would put the ear probe and point it out to somebody. You don't have to do that. There's no pictures on the comps, so you're not going to have to label a picture or anything like that. And in your auricular class, I mean, maybe they've changed it from when I took it, but I remember when I was taking auricular, there were all these different systems. There was like the CAM system, the Shanghai, Cropege, Nogier. There were all these different systems of auricular acupuncture that we learned. And, in this system, the kidney point's here, and in that system, the kidney point's there. The good news for comps is it just sticks with the CAM. They're not going to ask you in Cropege or in Nogier or in this or that. It just kind of sticks with the CAM points. And it mostly just focuses on what structure of the ear is the point located on. That's really the main focus for Comps 2 as far as auricular goes. It's only a few questions, and it tends to focus on what structure in the ear do you find the point. In other words, is it in the triangular fossa? Is it in the cavum concha? Is it on the lobe? That kind of stuff. So we can really narrow this down. Like we'll go through each of the structures and we'll highlight some of the key points to make sure are on those structures. We'll narrow it down quite a bit. I mean, they could ask you some functions, but the thing with functions is like most of the functions, I mean, the name of the point kind of tells you what you use it for. I mean, like if it's called the kidney point, you use it for kidney disorders, right? I mean, most of the functions are not overly specific. It's like if you have a knee injury, use the knee point. So there's really not that much they can get into with functions. That's why most of it really does just come down to like structures on the ear and which points are located on those structures. So let's go through that. So let's start with the helix. So the helix, remember, is this thing here that essentially goes around the outer perimeter of the ear. The helix there. And the helix, there's going to be points like it's not labeled in this particular picture, but around this area near the large intestine and everything, there's a hemorrhoid point. That's one to know. Hemorrhoid point. If you go to the top of the ear, there's the ear apex point. Then here near Darwin's tubercle, this little bump here that they call Darwin's tubercle, there's a point called liver yang. And those are really the biggies because look at the remaining ones. Like they're named for the fact that they're on the helix. Helix 1, helix 2, helix 3. So you're not really likely to get a question that says like where is helix 1 located, and the answer is it's on the helix. So it doesn't make for a very good question. So kind of the big ones for the helix, I would say no hemorrhoids, no ear apex, no liver yang. Now, two of them, pretty obvious what you use them for. Hemorrhoid point used for hemorrhoids, liver yang you use for things like liver yang rising, stuff like that. The ear apex, though, that's a little less obvious because you don't really use it to benefit the ear apex. We use it for more systemic conditions. So it's used to clear heat, like high fever, i.e., high fever, inflammation. It's used for things like hypertension, even pain. So I'll put this in parentheses here. So, so the ear apex a little less obvious in terms of functions. You could get a question that asks, like, what would we use the ear apex for? Sometimes, remember, we bleed it. We might use a lancet and bleed the ear apex, get a few drops of blood out, and that could be used to clear heat or to treat hypertension. So a couple things there. Then you've got this little area that partially goes under the helix, but partially sticks out a little bit. This area here called the scapha. The scapha. And the theme of the scapha is the upper extremity. So within the scapha, you can see there's the clavicle, shoulder, elbow, wrist, fingers. So you want to know anything related to the upper extremity is in the scapha. Clavicle, shoulder, elbow, all the major joints, wrist, finger. So if there's something upper extremity wise going on, you're thinking the scapha for that. Then we continue inward. And here you have the anti-helix. Here you have the anti-helix. And the theme of the anti-helix is the trunk. That's the theme of it. The anti-helix is well, actually, I don't know why I use parentheses here. The trunk. And that would include things like you see the abdomen, the chest, areas of the back. So you see like cervical vertebra. Some of it's mixed in here, but cervical vertebra, lumbar, thoracic, essentially the trunk area, the body core. So the back, the abdomen, the chest, those areas, those are all going to be found in the antihelix. Then we have the cruises, the superior antihelix cruise and the inferior antihelix cruise. So the superior antihelix cruise. And the theme for that is the lower extremity. The lower extremity is the theme for that. And you see that's up here. So you see you have hip, knee, ankle, heel, toe. It's all lower extremity stuff. Hip, knee, ankle, heel, toe. And they're used for what it sounds like, right? They're used for, you know, pain in the ankle, pain in the knee, and so on. And again, comps, it's not like in class. You know how in class, maybe you might have had questions like, which point is more superior? And it might be something like toe and heel, and you're trying to picture in your brain, like, God, which one was a little higher? It doesn't really get like that on comps. Comps will really more just ask you, where is the ankle point located? A, the helix, B, the scapha, C, the antihelix, D, the superior antihelix cruise. And you would have to know that it's located in the superior antihelix cruise. Then we have the inferior antihelix cruise. And the theme of that is basically the pelvic area. pelvic area. So that you can see here, you have buttocks, you have ischium. So buttocks, ischium. And then also, this is where that point, this is a very well known common point. So that point known as sympathetic is also here. Sympathetic can regulate autonomic nervous system function. So that one's a little bit unique, but the rest are just kind of named after structures and you use them for problems with that structure. So, you're having buttock pain, use the buttock point. Then you have here the triangular fossa. And even though there are a few things in the triangular fossa, really the main thing that comes up against comps wise is Shenmen. Triangular fossa. You want to know Shenmen. And I think most people know Shenmen is generally used to just calm the Shen, calm the mind, that kind of thing. Then we go to this area in here, the cavum concha and the concha. Now you can see it gets very cluttered. There's a lot of organs in each. So the main theme is that it's organs. Both concha, the main theme is that it's organs. And we'll narrow down which ones primarily to focus on. So the cavum concha, the main theme is organs. And the main ones to know for the cavum conchas, the lung, the heart, the spleen, and then you can see like the trachea, esophagus. So the lung, heart, spleen, trachea, esophagus. I wouldn't worry too much about the others. Those would be the main ones for this to know. Then we go to the concha. And again, the main theme again is organs, but different organs. So in the concha, you can see you have the stomach, you can see you have the liver, the gallbladder, stomach, liver, gallbladder, kidneys, pancreas, duodenum. So those again would be, again, there's others, but those are the main ones to narrow it down to. Those are the big ones to know from in here. All right. Any questions on any of that so far? Just a couple more things. All right. So just a couple more areas. This little area here is known as the antitragus. And the antitragus, mostly we're thinking headaches is kind of the main theme here. So this is the point where, there's a brain point, and sometimes people refer to it as brain for pain because we mostly use it for like headache type things. And then there's a point for each of the regions of the head. So there's a point for temple, occiput, and front forehead. And again, mostly we're using that for headaches. Mostly we're using it for pain in those regions. So that's here on the antitragus. And then lastly, we have the lobe. And the general theme of the lobe is think the face. There are a couple of things that aren't technically on the face, but they kind of make up the facial area in a way. Like, for example, the tongue The tongue's not on the face per se, but sometimes when you smile, the tongue is part of some people's look. Some people smile and they kind of use their tongue, like, so in a way, it could be part of the face. So you have the tongue, you have the jaw, you have the eye, and you have the tonsil. Again, tonsil's not really technically part of the face, but it is all in that general area. They're located in the back of the oral cavity, so it's all part of that general area. All right. Don't worry about like zone one, zone two. I've never seen anything come up about like whether it's in zone one or zone two. Like just more generally that the eye point is located on the lobe, jaw point is located on the lobe as opposed to being located in the symbocaccia. So don't worry too much about all the zones and everything. And that's pretty much it. Like I've never seen anything come up about the back of the ear. Like I know there's certain redundancies where it's like there's also a spleen point and a heart point behind the ear. I've never really seen that come up on the comps. Just a lot of these big points on the major areas of the ear. If you know what we highlighted here, you should be able to answer, you know, the huge majority, if not all, of the auricular questions. Right. And just as a quick reminder, remember that the way auricular acupuncture works is you're almost, if you envision the upside down fetus in the womb, that's sort of like where a lot of these points fall, is where these things would be located in this upside down fetus. That's why the head and face points are down here and the points like toes are up here. It's the idea of like the ear sort of resembles an upside down fetus in the womb. So a lot of the things that are in the lower part of the body are up here, and the things that are in the upper part of the body are down here. So that's generally how this is structured. All right. That should really narrow down auricular. Basically, in like 20 minutes or so, we narrow down a whole course worth of material in a way that will cover like the key things you need to know for comps. So any questions? All right. You got all this, Maggie? Okay.
Got it.
All right. So next we have a pretty large handout that we're going to start. That'll take us through pretty much the rest of the class. And this handout you can see has a little bit of everything. We're going to cover it's bio. I mean, it's the bio section of the exam, but we're going to go through the digestive system, the respiratory system, the nervous system. That'll include O&E1 stuff like cranial nerves and all of that, and even some general pharmacology things. So this handout will include a little bit of everything for the bio section. Now keep in mind, we're about halfway through the comp review class now. Like we're close to 2.5 classes in, and we still have two more to go. We have the rest of this class and two to go after that. You already have the material really for most of it. Like the Chinese medicine theory stuff. Again, we said that that's all the same universe of material as first year comps. So it's just all those same handouts. And I gave those all to you the first day and kind of went through them. You've got all the stuff to study for that and be successful on that. And now that we've finished auricular, you basically have everything for the acupuncture section. You've got all the handouts from the first year comp review that you've all already passed. That's, the things like point functions and Soon measurements and all that. We went over the extraordinary meridians, the key things you need to know there. And we just went over the key things you need to know about auricular. So now you pretty much have, I mean, you're only in week 4 of the term and you pretty much have all the material for the Chinese medicine theory section, for the acupuncture section, the law and safety section. That's the same universe of material as first year. So that's just that handout I gave you on law and safety. We definitely have some more bio topics to go through. We're going to do that starting now. And we will talk about the case study section. So we do have some things coming still. But yeah, I mean, you've got a lot of the material. You got a lot of the stuff that you need to start looking at. All right. All right. Well, if no questions then for now, we only have one guest, but if Maggie, if you don't have any questions, we'll dive into this handout then. So the digestive system. So first off, just a reminder of the anatomy. Just like with first year, they can ask basic anatomy questions, but also they could ask about disease conditions and pharmacology and all that. This handout's going to include everything. So you want to remind yourself, what are the anatomical landmarks? What are the parts that are involved in the digestive system? What's the order of those parts? So you want to know things like food goes in the mouth, into the oral cavity, then into the pharynx, then into the esophagus, then into the stomach. And I have all of those parts listed in order. And then we elaborate on what happens in them. But you should know the parts in order. So stomach, then we go into the small intestine, and there's the three sections: duodenum, jejunum, ileum. Then we go into the large intestine down here, the cecum, the ascending colon, all those parts in order. We mention other things throughout, like some of the accessory organs, but you want to know, like, these are the parts of the digestive system. This is the order, and they are listed in that order. So, first thing, of course, we put food in our mouth, we chew it up, we mix it with saliva, we break it into smaller pieces. And mostly the mouth, you're just chewing it up and breaking the food into smaller pieces. But remember, there is one key thing. In the saliva, there's an enzyme called salivary amylase, or you could just say amylase. And remember, that begins the process of digesting carbohydrates. It begins the process of taking long chains of glucose and breaking them down into smaller chains. So a common question to come up is, where does carbohydrate digestion begin? And the answer would be, it begins in the mouth. So we start chewing the food, we start mixing with saliva, any carbohydrate, the digestion process begins. Then we swallow it, and it goes from our oral cavity into the oropharynx. And the oropharynx is just the section of the pharynx posterior to our oral cavity. And you want to make sure that you know that pharynx is a passageway for food and air. So the water that you swallow passes through the pharynx. Any air you breathe passes through the pharynx. And make sure, don't confuse that with larynx, because larynx is air only. You don't want food going into the larynx. Now, the reason that food doesn't go into the larynx is because part of swallowing is the epiglottis closes. The epiglottis, remember, is that little flap on top of the larynx, and it covers the larynx. It prevents food from going in there as part of swallowing. So you should know the epiglottis is that structure that covers the larynx, prevents food from going in there. So instead of going into the larynx and going into the airway, food, water should go into the esophagus. So another part of swallowing is the larynx gets covered, and the larynx is the entryway into the respiratory tract, and the esophagus gets popped open. And that just all happens via involuntary means as part of swallowing. So the esophagus pops open, and now the food goes down the esophagus. And remember, the esophagus is posterior to the trachea. So if you're putting your finger here and touching like Ren 22, that structure you're feeling is the trachea, and the esophagus would be posterior to that. And then not really very much happens in the esophagus other than muscular contractions and such to push everything down to the stomach. There's no enzymes produced in the esophagus. There's no digestion or absorption happening in there. It's just essentially a tube that's going to take what you swallow down to the stomach. So not too much to say about the esophagus. Then whatever you swallowed is going to empty into the stomach. And a really big thing about the stomach is this is where protein digestion begins. This is where we're going to first start secreting protein digesting enzymes, and we're going to mix it all up with whatever we've swallowed. It'll all mix up in the stomach, and we'll begin protein digestion there. And there's a couple of key cells in the stomach. There's the parietal cells and there's the chief cells. The parietal cells make two really important secretions. They make hydrochloric acid and they make what we mentioned earlier, intrinsic factor. Hydrochloric acid basically is going to start denaturing proteins. It's going to start causing proteins to unfold and expose more surface area. It'll also destroy microbes. If there's any infectious material on your food, it'll destroy that. So it plays a helpful role in immunity, disease prevention. Intrinsic factor, as we already mentioned, remember, helps facilitate the absorption of vitamin B12. Without intrinsic factor, you can't absorb vitamin B12. Now, the vitamin B12 doesn't get absorbed right there in the stomach, though, and this is a point that does sometimes come up on exams. The intrinsic factor binds to the B12 and kind of packages it, and then it continues on into the small intestine, that package, and then you ultimately absorb it at the distal part of the small intestine, in the ileum of the small intestine. So it binds with the intrinsic factor in the stomach, but you don't absorb it until a little bit later on. And remember, you need the intrinsic factor in order to absorb it. Without intrinsic factor, you can't absorb it effectively. So make sure you know those parietal cells because they make two important things, hydrochloric acid and intrinsic factor. And then there's also the cells called the chief cells. And the chief cells secrete something called pepsin. And pepsin is a protein digesting enzyme. Pepsin will essentially take long chains of amino acids and break them up into smaller chains. So pepsin, and that's right in the name because chains of amino acids are held together by what we call peptide bonds. So the enzyme is called pepsin because it breaks peptide bonds. So yeah, make sure you know these. And for any of you, I mean, I'm proud of you if you remember this detail, but if any of you remember from AP4 that there's a little bit of a technical thing with like the chief cells make pepsinogen, which is an inactive enzyme, and then it gets activated into pepsin. And there's a little bit of technicality there. The comps don't get that nitpicky. So don't, if you remember that, that's great and that's fine. But comps is a little more big picture than that. So it doesn't get into that. So don't worry about that distinction. If you just know basically there's pepsin in the stomach, and it digests proteins, you'd be fine. Now, as far as some applicable disorders that involve the stomach and the esophagus and the upper part of the GI, the thing that tends to come up is gastroesophageal reflux disease, GERD for short. Some people mistake this and think that GERD is a result of too much acid, but it's not really the amount of acid that's the issue. I mean, even though that's possible, usually it's not really a matter of the amount of acid. It's just more that the gastroesophageal sphincter that should open to allow food to go into the stomach, but then close so it doesn't go back the other way. For some people, that sphincter is it's weak. It's just weak. It doesn't seal properly. And therefore, when they start mixing the contents of their stomach with hydrochloric acid and pepsin and everything, some of that regurgitates and it comes up in the esophagus. And the esophagus is just not as well protected as the stomach lining for that acidic environment. The stomach lining, you might remember, has a thick mucus layer that neutralizes some of the acidity, on the surface of the stomach lining. The esophagus just doesn't have that same layer, that same degree of protection. So when the acid regurgitates up into the esophagus, it starts burning the esophagus. It starts damaging the tissue. So usually shortly after eating, when they start releasing acid, some of it regurgitates and it creates this retrosternal pain, this burning pain in the area of their chest. It's not really that the heart's burning, but people perceive it as heartburn because the esophagus runs just posterior to the heart. So the esophageal tissue starts getting, burnt, damaged, and they perceive it as burning pain in the area of the heart. So it gets the nickname heartburn. And then it leads to food stagnation type symptoms that we would think of from Chinese medicine, like belching, foul breath. They get the sour taste in their mouth from the regurgitation. Sometimes they might aspirate some of that acid and irritates the vocal cords. And that can lead to, hoarseness, sounding hoarse over time. If they aspirate enough of it, it might even trigger asthma symptoms, because it could irritate the bronchioles. So typically, if somebody has this condition, they might be taking antacids. They might be taking things like Tums or Rolaids that just neutralize that acid, make it more alkaline so it's less irritating. Or if it's really severe, they might take what they call proton pump inhibitors, which reduce the production of acid. So they just don't make as much acid to begin with. Now, that name, proton pump inhibitors, might sound like kind of an odd name, but the reason it's called a proton pump inhibitor is because think about what acid is. It's hydrogen ions dissolved in a solution. And isn't a hydrogen ion basically just a proton? Think about it, right? Hydrogen atoms have one proton, one electron, but hydrogen ions give away the electron. That's why they have a positive charge. So what's left? It's basically just a proton. So that's why they call them proton pump inhibitors. And you should know the basic definition of a hiatal hernia. Remember that there's an opening in the diaphragm for the esophagus to pass through on its way to the stomach. And that opening is called the esophageal hiatus. It allows the esophagus to pass through the diaphragm. In some cases, the stomach could push up through that opening and you get portions of the stomach going up into the chest cavity. So the stomach is essentially herniating through the esophageal hiatus. And so they call it a hiatal hernia. That could cause pain and discomfort in the chest, and it increases the risk of GERD. So it kind of goes along with this. A person's more likely to have GERD if they have a hiatal hernia. All right. And then at the distal part of the stomach, there's that pyloric sphincter. And that sphincter should close to allow for mixing in the stomach and then little by little open to allow what we now call the chyme to go into the small intestine. So you do want to make sure that you know that that distal sphincter, that sphincter in the distal part of the stomach is called the pyloric sphincter. All right. So it is a good breaking point. Any questions, Maggie?
I cannot wait for the break. Thank you.
Well, thanks. Can't wait to get away from you, Matt.
So
My
what
kid.
time should we back?
10 minutes. Just take the usual 10-minute break.
Great. Thank you.
Yep. All right. Let's continue. Any questions? All right. So let's continue. We're working our way down the GI tract and the digestive system as a whole. So we had gotten to the pyloric sphincter that separates the stomach and the small intestine. Then remember the small intestine, there's the three sections in order: duodenum, jejunum, ileum. And that is a common question that can come up. What are the three sections of the small intestine in order? And you want to know that the small intestine first will finish any digestion that still has to be done, because remember, we're not usually done with digestion at this point. There's still more digesting to be done, and the small intestine will finish that. But this is the primary site of nutrient absorption. So the primary site for absorbing of major macronutrients will be the small intestine. And you may recall the inner lining of the small intestine is not smooth. There's actually these projections, they're microscopic, but there are these projections called villi and microvilli, and those are there to increase the surface area. They increase the surface area for better absorption of the nutrients. Because essentially the concept of surface area is that the particles, the nutrients that are passing by, they need to come in direct contact with the inner lining of the small intestine in order to pull it into the blood. If it just sort of stays in the middle, then it's just going to end up going out the other end. So you want to increase the amount of nutrient to mucosal layer contact. Right? Now, just illustrating the importance of surface area, we know that celiac disease, one of the consequences of unmanaged celiac disease, is that it triggers such a degree of inflammation that over time it actually causes the villi to become blunted. So, in other words, the villi becomes shorter and smaller, and therefore there's a loss of surface area. And therefore, somebody with unmanaged celiac disease can develop significant malabsorption problems where they can become deficient for a variety of nutrients. They could become anemic, for example, from lack of iron absorption. They could develop osteoporosis from lack of calcium absorption, and even just things like weight loss and muscle wasting from like lack of protein absorption. So celiac disease, remember, of course, is triggered by people that are having a reaction to foods containing gluten. It triggers an inflammatory reaction, leads to a lot of pain and discomfort. But over the long haul, yeah, it damages the villi. It could lead to significant malabsorption. Now, remember, in addition, we've got a couple of, well, three. We have three accessory organs. And these organs, they're considered accessory organs because they're not part of the GI tract itself. In other words, the food or the chyme is not going through the liver the way it goes through the small intestine or through the stomach. But these organs do play a role in digestion. They make some critical enzymes, critical substances that are then sent via ducts into the small intestine. So the liver, for example, makes bile. And bile, you may recall, emulsifies lipids, or you could say emulsifies fats. Now, remember, emulsify is not the same thing as saying digest. You can't use those interchangeably. You do have to, so if one option said emulsifies fat and another option says digest fat, it's not a trick question. It's not like, wait, there's two right answers. There is a difference between emulsifying and digesting. Emulsify basically is more, it's physical. It's a physical change. Nothing chemical changes. So it groups lipids into smaller droplets, which again increases the surface area. So now there's more surface area to come into contact with the enzymes once the enzymes are produced. But emulsifying doesn't result in any kind of chemical change. Like it's still the same fat that originally entered the person's mouth. It's just smaller droplets of it. Nothing has been broken down chemically, and digestion is a chemical change. So the liver makes that bile that emulsifies fats or lipids. And remember, the gallbladder stores the bile. So let me just go down here. The gallbladder, ultimately stores the bile and then pumps it into the duodenum of the small intestine when needed. Make sure you don't fall for the fake choice that the gallbladder makes bile. A lot of people fall for that. Gallbladder does not make bile, the liver does. Now, remember, the liver also does other things outside of its digestive function. So remember that the liver also makes and breaks down vital plasma proteins. So the liver makes things like albumin and clotting factors, and then breaks those down when the proteins get old and less functional, breaks them down into amino acids, and then can make new ones. So albumin, that plays an important role in regulating blood volume and blood pressure, and how much fluid is in the blood. Clotting factors help us to clot the blood when there's an injury. Complement proteins play an important role in immunity, and all these are produced by the liver. As a reminder, remember that's the reason there's that hepatic portal vein, or at least one of the reasons why there's that hepatic portal vein that takes blood from the digestive tract to the liver before it goes anywhere else, because the liver gets first dibs on amino acids to make plasma proteins before the amino acids go into general circulation. Same thing with storing glucose. The liver gets first dibs on the glucose because the liver stores glucose in the form of glycogen. And then when blood sugar levels drop, we could break down that glycogen and release it into the blood in order to maintain blood glucose levels. So the liver gets first dibs on glucose that we absorb in the diet, amino acids, because of these functions. Remember, muscles also store glycogen, but they just store it for their own personal use. Muscles are really active tissues. They go through a lot of ATP. So they store glucose in the form of glycogen for their own personal use. The liver stores it to benefit everybody. When I say everybody, I mean like all the organs, all the cells of the body. Obviously, we're not giving it away to other people. And then, of course, another reason that we send the blood from the GI to the liver first before it goes into general circulation is the liver, we know, detoxifies and breaks down certain waste products, certain toxic substances. So maybe there's something we absorb via the diet that maybe is harmful to us. So we let it go through the liver first prior to going into general circulation so the liver can break some of it down. Now, the liver also detoxifies bodily substances like bodily waste products that could be harmful. Not just things we take in from the outside, but there's toxic compounds that get produced as part of our metabolism that the liver also breaks down. And a really common example to come up on tests is that when we break down amino acids, or another way of saying that is break down proteins, because remember, amino acids are the building blocks of proteins. When we break those down, like sometimes we have to convert protein into fat or protein into glucose, we end up with leftover nitrogenous waste in the form of ammonia. Because remember, amino acids, proteins, they have nitrogen in them. Glucose doesn't, fat doesn't. So if we're breaking down proteins and converting it into glucose, let's say, we're going to have leftover nitrogenous waste in the form of ammonia. Ammonia is toxic. So the liver can convert that ammonia into urea, which is a little less toxic. We could tolerate urea more. I mean, even urea will get toxic if it builds up too much, but we can tolerate it better than ammonia. And then the kidneys can filter the urea out of the blood and we get rid of it via the urine. So that's a really common detoxification process for the liver. Break down ammonia, which is a byproduct of protein breakdown, convert it to urea, release it into the bloodstream, and then the kidneys filter it out of the bloodstream. And we get rid of it in the urine. So these are some really key things that the liver will do for us. They can come up on this exam for sure. Now, as far as some disorders go, there's hepatitis, and hepatitis by itself just means inflammation of the liver. So there could be a lot of things that cause hepatitis. There's viruses like hepatitis A, hepatitis B, C, and so on. But it could also be injury from like chemical damage from drugs, alcohol, so it could just be like an injury, like some substance that's injuring it, like certain, acetaminophen is known to cause liver damage. So regardless though, whether it's viral, whether it's due to alcohol consumption, drugs, some other thing, if the liver becomes inflamed, we call it hepatitis. That would usually lead to pain in the area of the liver, so predominantly focus in the right upper quadrant of the abdomen. If it's infectious, it might present with a fever, chills, body aches. Where if it was alcohol related, there might not be a fever necessarily. But certainly if it was due to a virus, there would usually be a fever accompanying that. And then what can happen is the liver starts to remember one of the characteristics of inflammation is loss of function. So the liver may stop doing some of what it's supposed to do. And you may remember that one of the functions of the liver is to remove bilirubin from the blood. Bilirubin, you may recall, is a byproduct from red blood cell breakdown, specifically the hemoglobin breakdown. And bilirubin is yellowish in color. It's a yellowish compound. Normally, the liver removes it from the blood on a steady basis and sends it down into the intestines and we defecate it out. But if the liver function is compromised, the liver may fail to do that. And now the bilirubin builds up in the blood, spills into the body tissues, and makes the person appear yellowish, what we call jaundice. So that's why you often see jaundice with liver disease. And also, you can see constipation or diarrhea develop with hepatitis, because the liver makes bile and that helps digest, well, helps with the process of digesting fat. It sets the stage for digestion. Because the liver makes bile, it can compromise fat digestion and absorption. And that could lead to like oily stools and stuff like that. But it can also lead to constipation sometimes because when there's significant abdominal pain signals going into the spinal cord, that can sometimes shut down peristalsis. So that's why it could go either way depending on the severity, depending on what's going on in the moment. Now, as far as some key labs go, there would likely be excess bilirubin in the blood, what we call hyperbilirubinemia. And there's a couple of liver enzymes. These are enzymes that are found in liver cells, AST and ALT. Normally, they're found inside liver cells, not in the blood. So if you find these enzymes at really high levels in the blood, it usually indicates liver damage, that there's some kind of liver damage, and that's why the enzymes are spilling out. It doesn't necessarily tell you exactly what the cause is. It doesn't tell you, like, is it liver cancer? Is it an autoimmune process? Is it hepatitis B? But it does tell you that there's some kind of liver damage if you see these enzymes. You want to recognize those as liver enzymes and know that when elevated, they indicate some kind of liver damage. Cirrhosis, remember, is when there's been such long term damage to the liver, whether it be due to an infection, whether it be due to alcoholism, whether it be due to drug use, whatever it might be that's causing it. There's been such long term injury and damage to the liver that at this point, there's little to no functional liver tissue left. Basically, the liver's just become a mass of like scar tissue at this point, connective tissue. So essentially, when somebody has cirrhosis, they need a liver transplant. They have a completely non-functioning liver or a very minimally functioning liver. Now, just one key point on this, I have seen this happen on comp exams where they'll give you a scenario like a person is 23 years old, they're in college, they went out drinking with their friends the night before or something like that. This morning they woke up and they have some abdominal pain, they have some jaundice. Which of the following do you think is most likely? And I've seen people pick cirrhosis as the answer. Keep in mind that cirrhosis is like something that's typically years in the making. It's something like years and years of, chronic alcoholism or something like that, years and years of chronic liver damage. It's not something that an otherwise healthy 23-year-old just wakes up with one morning. Keep that in mind. Don't be too quick to pick cirrhosis, in other words. Now, gallbladder, something a little more common, like if somebody were to just like one morning be having, upper right quadrant pain, something certainly more likely than cirrhosis would be gallstones. Remember that the cholesterol is eliminated in the bile duct with the bile. So bile contains a certain amount of cholesterol in it. And sometimes that cholesterol can clump together and lead to stones, what we call gallstones, or the more technical term, cholelithiasis. And when those stones start to accumulate in the gallbladder, they can create pain when the gallbladder contracts. So the gallbladder starts contracting around these stones, and the stones irritate the gallbladder wall, leading to the person experiencing pain. And most commonly, they feel the pain when they eat fatty foods, because remember, fatty foods is when you need the gallbladder to contract. Because, again, bile emulsifies lipids. So when the person eats fatty foods, that's when you need the bile pumped into the duodenum. So fatty foods triggers gallbladder contractions, and usually that's when their pain is most noticeable. And obviously, anybody could develop a gallstone. There's no absolute rules, but most commonly, the typical patient profile is the four F's. Most commonly female, most commonly they have a higher body fat percentage. Most commonly they've had children, and most commonly they're in their middle age, they're in their 40s. And there's a reason for that. Like estrogen actually promotes the liver to eliminate more cholesterol. So that's why it tends to be more common in females because of the higher estrogen levels. Pregnancy actually further enhances that, because the combination of estrogen and progesterone and the estrogen being at sustained levels, pregnancy actually enhances that. So more cholesterol elimination by the bile. So therefore more potential for the clumping. And overweight, like the more body fat, the higher the body fat percentage, it's like, well, the more lipids in the body as a whole. So there is just that greater likelihood of more cholesterol removal and more of that going down the bile duct. And, the middle age thing is just, usually it's one of those things where just over the years it becomes more likely. So basically, they get pain in the right upper quadrant, worse when they eat fatty foods. They may get nausea, vomiting. Sometimes they have to have their gallbladder removed. This is what we call cholelithiasis, gallstones. Somebody comes in with acute right upper quadrant pain. That's probably the first thing to rule out. Certainly more likely than cirrhosis, and even more likely probably than just like acute hepatitis. Then we've got the pancreas. Remember, the pancreas will make some key digestive enzymes. It'll make amylase that'll digest carbohydrates, lipase to digest lipids or fats, trypsin to digest proteins, and it also makes bicarbonate that neutralizes acid from the stomach. So the pancreas is really critical when it comes to the digestion of all of our major macronutrients. Now, as far as the condition goes, also more common than, especially if you're talking about somebody that scenario I mentioned earlier, a person that goes out drinking the night before, they're an otherwise healthy 23-year-old college student or something, and they go out drinking with their friends the night before, and then they wake up the next morning and they have severe abdominal pain and jaundice. Much more likely than hepatitis, and certainly cirrhosis is pancreatitis. So some people just have a tendency to this. For some people, alcohol seems to cause their sphincter of Oddi, which is the sphincter that both the bile duct and the pancreatic duct feed into. For some people, alcohol seems to cause that sphincter to spasm. That opening could also get blocked by a gallstone. There's other causes, but alcohol is often a contributing factor here. It causes that sphincter to spasm. And if that sphincter goes into spasm, what happens is then the bile backs up, the pancreatic enzymes back up. When the bile backs up, that leads bilirubin and everything to back up. So the person might get jaundice. When the pancreatic enzymes back up, what can happen is those enzymes can auto digest the pancreas itself. They start basically digesting the pancreatic cells. So it leads to severe inflammation and injury to the pancreas. So they get this mid epigastric pain that radiates to the left and between the shoulder blades. It can have a sudden onset, like wake up with it one morning after a night of drinking, nausea, vomiting. It hurts to breathe because every time the diaphragm contracts, it presses on the pancreas. Their abdominal muscles go into spasm to protect the pancreas. Again, they might get jaundice because of the backup of bile. Now, certainly some people confuse this with like, it sounds maybe like a liver thing because alcohol could be involved. There might be jaundice. But what they'll usually do if on a test question like this is they'll tell you the labs. And instead of saying that the liver labs that we mentioned, instead of saying AST and ALT are elevated, the liver enzymes, they'll specify that amylase and lipase are elevated, pancreatic enzymes. And that's what gives you the clue that, oh, it's actually the pancreas that's being damaged, not the liver. So if you see something about amylase and lipase levels being elevated, being detected in the blood, that would more indicate that it's pancreatitis as opposed to hepatitis, even though some of the symptoms might overlap. All right. And I know for certain there's a pancreatitis question or two in the test bank. So I'll make sure you know that. Any questions? All right, then we go to the large intestine. And same thing as the small intestine, there's sections of it. So it starts with the cecum, then it feeds into the ascending colon, the transverse colon, the descending colon, the sigmoid colon, and then into the rectum. And then from there out the anal canal and anal sphincter. Primarily, the large intestine will absorb water just to make the stool more like well formed as opposed to coming out as like a liquidy mess every time. And we have a few key disorders that come up. Yeah. Excuse me. So I have a few key disorders that come up with the large intestine. Some of them could also affect other areas. So like Crohn's disease, a very common question to come up on whether it be COPS boards is differentiating Crohn's disease from ulcerative colitis. So there's overlap for both. They both involve inflammation. They both involve intestines, but key difference is the locations and such. Crohn's disease, they're both autoimmune in nature. So it's inflammation for no good reason. Crohn's disease, though, involves inflammation of what we call the submucosal layer, which is one of the middle layers of the intestinal wall. Where ulcerative colitis, it involves the innermost layer, the mucosal layer, the layer that comes into direct contact with the feces. So, because of where the inflammation is, there's a little bit of a different appearance when you look in there if you do a colonoscopy or something. In Crohn's disease, it creates what we call a cobblestone appearance. There's basically like pockets of swollen areas. It looks like, little cobblestones, like on a cobblestone street or something. Where ulcerative colitis, it just kind of looks like a bunch of, just redness. It just looks like a continuous area of redness. Doesn't have the same, like pockets of fluid. And that has to do with, again, the layer where the inflammation is occurring. Also, Crohn's disease can occur anywhere in the GI. Now, it's most common in the ileum of the small intestine and the colon, but you can find Crohn's disease inflammation anywhere in the GI. Ulcerative colitis, I mean, it's called colitis because it's always in the colon. Typically, it starts in the rectum and works its way up. And you may remember that Crohn's disease is known for what they call skip lesions. So there's pockets of inflammation that sort of skip around. So it's like there's a pocket of inflammation, then there's some healthy tissue, then there's a pocket of inflammation again, then there's more healthy tissue. It's known for kind of skipping around. Whereas ulcerative colitis is always like one area, one continuous area of inflammation. And then at some point it just stops. But there's like one continuous lesion up to that point. May continue to spread over time, but at any given moment, it's just like one continuous area. And some of those differences create some differences in the symptoms. So, like in both cases, they get diarrhea because intestinal inflammation is going to prevent water absorption. So, in both cases, they're going to get diarrhea. But Crohn's disease, the diarrhea is not bloody because the inflammation, again, is in that middle layer. Ulcerative colitis, though, it is bloody because the inflammation is in that deepest layer, the layer that comes into contact with the feces. So that layer does actually erode, ulcerate, and they do get bleeding. Crohn's, not so much. In both cases, they get abdominal pain. But because Crohn's disease can affect the small intestine, Crohn's disease would be more likely to cause something like malabsorption. Ulcerative colitis, not so much because it only affects the colon. We've already absorbed nutrients at that point. But because ulcerative colitis always involves the rectum, ulcerative colitis is more likely to cause fecal incontinence because essentially the rectum is so swollen, they really can't tell when they actually have to have a bowel movement because it just sort of always feels like swollen and full that it's really hard for them to tell sometimes when they really have to go. It dulls the normal sensation. So you just want to know some of the key differences between those two things. Then we get irritable bowel syndrome. And irritable bowel syndrome, remember, is in some ways, it's kind of like a garbage can diagnosis. The person comes in with digestive complaints. A lot of things are listed here that abdominal pain, bloating. Some people complain of constipation. Some complain of diarrhea. For some people, it alternates. They have usually a history of mental emotional stress, food avoidance, because it's just so uncomfortable, lots of gas. So a lot of times people remember the symptoms by the alphabet, A, B, notice the order, A, B, C, D, E, F, G. But the key thing with irritable bowel syndrome is the person's coming in with all these digestive complaints. So of course you try to rule out the usual suspects. It's like, all right, well let's see if they have let's test the feces. Let's take a fecal sample, let's test. Maybe it's an infection. Maybe it's parasites. Nope, all looks clear there. Let's do some blood work. Let's check eosinophil levels. Maybe it's allergies. Let's maybe they're allergic to something they're eating, right? No, that seems all clear. Well, let's do a colonoscopy. Let's have a look in there. And they look in there and it's like no inflammation, everything looks normal. So this is one of those things where it's a purely functional issue. There's no structural abnormalities. There's nothing like metabolically wrong. That's at least nothing easily identified. So it's like a purely functional issue. And usually it's linked to a history of mental emotional stress. So oftentimes the signs and symptoms start during a moment of or a period of time where the person's under unique, mental emotional stress. And that essentially affects autonomic nervous system functioning. It affects the sympathetic parasympathetic balance. And it seems to, in the long run, result in like chronic digestive problems. Because, of course, the autonomic nervous system can regulate aspects of digestion. So it's kind of like a rule everything else out. And what you're left with is like, oh, I guess the bowel's just irritable. That's what we got. Then we have diverticulosis and itis. Osis is basically where herniations occur in the large intestine. Areas of the large intestine essentially herniate outward. They create like a little outpouching. We refer to it as diverticulosis if they're not having any symptoms. So like maybe this is discovered on a routine colonoscopy and we see that they're there. We see that structurally the person has these diverticula, but they're not causing the person any problems. They're not having any digestive complaints. So we would just say they have diverticulosis. But what can happen sometimes is that fecal material gets into these herniated areas, these outpouches, accumulates. The large intestine pulls water from it because, that's what the large intestine does. And then you have this dried out fecal material in there that irritates the large intestine wall and it leads to inflammation. And then it's really painful. It can lead to sharp stabbing pain. It can lead to potential rupture, and that could potentially be life threatening if it ruptures, because then you've got like waste material spilling into the abdominal cavity that can lead to peritonitis and shock. So they might have to do surgery in those cases. So, in other words, osis, there might be no symptoms. They just structurally have an abnormality. Itis is when one of those herniated areas becomes inflamed. And then that does definitely lead to symptoms. Very painful. Appendicitis is kind of the same concept as diverticulitis. I mean, the only difference, of course, is that the appendix is an actual, like, oh, see you later, Maggie, if you got to go. The appendix is an actual, like, anatomical structure, but similar to a diverticula, sometimes the appendix becomes inflamed, either because of physical trauma to the area, because it becomes infected. Sometimes fecal material gets impacted into it. But the bottom line is, regardless of what causes it, if it becomes inflamed, it's similar to diverticulitis. It's extremely painful, can lead to nausea, vomiting, fever. It could rupture. So that's why they often remove it. The main thing is just appendicitis, because it is a physical anatomical structure that does have a defined location. You would find it in the lower right quadrant of the abdomen, and that's where the pain would be located. Where diverticula is most commonly in the sigmoid colon. So, most commonly, you'll find the signs and symptoms on the lower left side of the abdomen, but it can be in other locations. Appendix is just, there's one place where the appendix is. And then lastly, for digestive, colon cancer. Remember that, and now they're changing the recommendation. They're lowering the age a little bit. Now they say 45, and it depends on if cancer runs in the family. But they do recommend routine colonoscopies. That you won't get a test question about the age because the exact recommendations change. But they suggest routine colonoscopies in order to look for polyps, because polyps are precancerous lesions in the colon where If you find a lesion while it's still in the polyp stage, that's not cancer yet. You can remove the polyp and essentially prevent it from ever becoming cancer. So there is this chance to nip what would otherwise maybe turn into cancer, nip it in the bud. So hopefully they're hoping that they find it some, well, obviously they hope they find nothing. But if they do find something, the hope is they find it in this precancerous polyp stage, remove it, and then prevent the cancer from ever forming. Now, if somebody does have full blown colon cancer, some key red flags would be, of course, blood in the stool, because as tumors grow, they lead to bleeding because they damage blood vessels and such. Any kind of change in bowel habits, because a tumor can create an obstruction and therefore alter the bowel function. And sometimes pencil thin stools, because the idea is that the stool's having to go around the tumor. It's having to squeeze past the tumor. So all of a sudden, the person notices their new normal is their stool's coming out really thin. That could be a warning sign. I know, Pam, we all occasionally have thin stool for whatever reason. Could be related to what we ate, could be related to inflammation. I mean, any number of things. It's more like you get concerned if it's becoming the new normal, right? And now it's just me in the recording again. So I would normally obviously check in for questions, but nobody's here. So let's go then into the respiratory system. Now, same thing with the respiratory system as we said for digestive. You want to know the anatomical parts in order so we could breathe through the nose or mouth. Not really much to say there. Then the air will go to the area posterior to the nose and the mouth, the naso and oropharynx. And same thing as what we said in the digestive system, both food and air passes through this area. But then air should go into the larynx. Remember, this is where the vocal cords are located. And during swallowing, it's covered by the epiglottis. So food, water should not go in here. If it does, it triggers a powerful coughing reflex. Or in the worst case scenario, it creates an obstruction and then, need like a Heimlich maneuver or something. But if everything's, working normally and we swallow normally, food, water should not go in here because the epiglottis covers it. But when we inhale, air should go through here. This is the air only passageway where the vocal cords are located. Then the air goes into the trachea from there. And remember, the trachea is anterior to the esophagus. We already mentioned that when we're going over digestion. So then, as far as a couple conditions that might come up, or really just one major one for the upper respiratory tract, is there are a number of upper respiratory infections, right? There's colds, influenza, COVID, even things like mononucleosis. For comps purposes, just no influenza. And, common cold is just kind of a more mild version of influenza. They're both viruses, but common cold viruses are very mild in terms of the damage that they cause to the epithelial lining, in terms of the symptoms they cause. Influenza is a much more aggressive virus. Now, as far as comps go, you want to make sure you know things like common colds, influenza, also COVID, also mono. They're all viruses. They're not bacterial infections, they're viruses. Influenza typically will cause a high fever, chills, significant body aches, headaches, sore throat, so on. In Chinese medicine, we might think of this as a wind heat invasion, where common cold is more mild, usually not much of a fever with a common cold. So the common cold we might think of as a wind cold invasion. But yeah, I mean, they're not going to nickel and dime you on like some minor difference in symptoms or anything like that. But definitely make sure you know they're viruses. They're not bacteria. They're not fungus. As far as some medications that might come up, remember, usually with upper respiratory viruses, there's really no medication. I mean, there are medications they can give you, for symptom relief, but most of the time people just go over the counter remedies, decongestants, things like Sudafed and stuff. And that takes us to a pharmacology thing that might come up. You should know the mechanism by which decongestants work. Decongestants like Sudafed, they contain pseudoephedra. That's why it's called Sudafed. It contains the compound called pseudoephedra. It's similar to ephedra that's in mahuang. And this is a sympathetic stimulant. Now, in relatively small doses, and if you do it via nasal spray or something, it'll usually just have a local effect and it'll cause the local blood vessels in the mucosa to constrict. And then that will lessen the degree of inflammation in there and therefore lessen the swelling and it'll, make the person feel less congested, less stuffy. But if people overtake these things, it could have a more systemic effect in stimulating sympathetic reactions in the body. And it could lead to things like anxiety, hypertension, tachycardia, palpitations, having trouble sleeping at night, nervous energy, that kind of thing. So yeah, in small doses, the hope is it just causes some blood vessel constriction, and then that lessens the degree of inflammation and swelling in the nasal cavity, so the person becomes less congested. But you take too much of it, it does stimulate sympathetic receptors, and it could lead to more systemic effects if you take more of it. So we want to know a couple of those key things. That's an example of like a pharmacology thing that could come up. All right. So then after the trachea will then split into multiple tubes that we call bronchi, and that's going to take air into the lung structure. Then we'll get into smaller and smaller bronchi that we call bronchioles. And one key condition we want to mention in regard to the bronchioles is asthma. Basically, asthma is a condition where the bronchioles overconstrict. Basically, the bronchioles are hypersensitive to stimuli in a person who has asthma. They're oversensitive to stimuli. Now, generally there is normally some constriction in the bronchioles with certain irritants, and that's how we protect the lung, the actual like alveoli tissue. But some people, those people that we would say have asthma, there's a certain hypersensitivity where the airway is overreactive to those kinds of stimuli, various environmental triggers. And it usually involves what we call a type 1 hypersensitivity reaction. The person usually has an accumulation of mast cells in the bronchial tissue that have IgE antibodies attached to them. And these antibodies are they're essentially abnormal antibodies. And they react to normal parts of the environment, things that we really shouldn't be reacting to, things like dust, pollen. So if a person inhales those things, they bump up against the bronchial wall. They interact with the IgE antibodies on the mast cells, and that results in a big histamine release in the area. And histamine, as we know, triggers inflammation. So it causes those bronchioles to become swollen and inflamed, and that makes them hypersensitive. So between the overconstriction because of their hypersensitivity, the swelling because of the type 1 hypersensitivity reactions with the antibodies and the mast cells, between those things, the airway narrows. And now the person can't breathe effectively. And that's what we call an asthma attack when something triggers that. So you want to make sure you know some of the mechanism behind it. Now, medication wise, a person would generally have an albuterol inhaler. Once they're diagnosed with asthma, they typically would have an albuterol inhaler. And those are in the category of what we call a bronchodilator. Similar to decongestants, bronchodilators contain sympathetic stimulants. If you only take a small amount in, via an inhaler, it'll usually just have a local effect. It'll stimulate the local receptors within the bronchioles to trigger dilation. Because remember that sympathetic stimulus dilates the bronchioles. So if you just take in a relatively small amount, it will generally just have a local effect. It'll trigger the bronchioles to dilate. It'll alleviate their asthma attack signs, help them breathe a little bit better. But if somebody uses their inhaler a lot, some of that's going to diffuse into the bloodstream and it might have more systemic effects and it'll lead to side effects similar to what we set up here for decongestants. It'll lead to things like anxiety, hypertension, palpitations, stuff like that. Again, because it's sympathetic stimulus. So make sure you remember sympathetic stimulus causes the airway to dilate. Then we go into the alveoli, and that's the end of the line. Those are the air sacs. That's the end of the respiratory tract. And remember, the air sacs are where gas exchange will occur. So this is where gas exchange will occur in the alveoli. Oxygen should diffuse from the alveoli into the capillaries and into the blood. And carbon dioxide should go the other way. And then we exhale the carbon dioxide. So we say gas exchange occurs in the alveoli. And remember that there is a substance produced by the alveoli called surfactant, and that's a really critical substance for breathing. Surfactant is said to decrease surface tension so the alveoli don't collapse during breaths. If it weren't for surfactant, every time you exhale, the alveoli would shrivel up. And it would be much harder to take an inhalation the next time because you'd have to reinflate from scratch. It'd be much harder. So surfactant prevents that from happening. We say decreases surface tension, which then prevents the alveoli from collapsing because there's less of that tension in the tissue and therefore makes it easier to breathe. Another way of phrasing that is to say that surfactant increases lung compliance. It makes the lungs more compliant, more receptive, easier to breathe. And if somebody doesn't have surfactant, the opposite happens. There is high surface tension. The alveoli do collapse, and there's decreased lung compliance. It's much more difficult to breathe. So make sure you know the term surfactant and what it's used for. And even though it is just me in the recording, this is a good breaking point because I need to rest my voice, take some water in, things like that. So I'll take a 10-minute break and then come finish up and we'll get as far as we get prior to 4 o'clock. All right, everyone, let's continue and we'll finish up for the day. So, some applicable conditions for the respiratory system. I would say, for the most part, these are pretty straightforward, but the hardest part that sometimes trips people up is a lot of the names, the terms are similar, right? They all begin with the letter P, or most of them do. And it's all like pneumo this or plural that or pulmonary this. And it's easy for people to get them confused. So make sure as you study that you are really clear on like which one is which. So pneumonia and pleural effusion. The reason I have them together, like one versus the other, is that they both involve fluid accumulation in the lung structure, but there's a difference in the location and also like a difference sometimes in the cause. So pleural effusion is where there's a fluid buildup, a fluid accumulation in the cavity surrounding the lungs. So typically in between the visceral and parietal layers, the visceral and parietal membranes of the pleura, what we call the pleura or the pleural membrane. So there's fluid accumulation in there. Now that could be due to an infection, but it could also be due to like trauma. It could be due to a circulation issue. There's lots of things that could potentially cause that, but it's a buildup of fluid within that space. And that puts pressure on the lung. So since there's fluid accumulating, it's compressing the lung and it could definitely make it painful and make it difficult to breathe. Right? But it's all about the location. So fluid in the cavity, that's what we call pleural effusion. Pneumonia, on the other hand, usually this is an infection, and this is an infection of the alveoli. So it typically involves bacteria or viruses making their way down to the alveoli, leading to inflammation and swelling of the alveoli and pus and fluid accumulation within the alveoli. And of course, that impairs gas exchange because now the alveolar membrane is swollen and there's fluid in there. So that impairs the movement of the gas molecules in and out of the blood. And that leads to things like shortness of breath, severe fatigue, because, oxygen levels are going to drop. There'll be general signs of an infection like fever, chills, stuff like that. So, key difference is pneumonia, fluid accumulation and inflammation in the alveoli, pleural effusion, fluid accumulation in the pleural cavity surrounding the lungs, pneumonia, typically it's an infection. Pleural effusion could be an infection, but it could also be trauma. There could be other things that cause fluid to build up in there. All right. Then pneumothorax, this is a common one to come up. It's certainly in the test bank because this is something we hear about a lot as acupuncturists that we have to be careful about this. And pneumothorax is air accumulation of the pleural cavity. So it's basically like pleural effusion, except instead of fluid accumulation, it's air accumulation. And that usually happens as a result of some kind of trauma. There's some kind of trauma to the lung that creates a little opening. And now when you breathe, some of the air you're breathing in seeps out into the pleural cavity and it accumulates. It creates a little air pocket. And then that air pocket gets bigger and bigger with each breath and can compress the lungs. And then it leads to the lung or lungs collapsing and it impairs breathing. So a person gets chest pain, shortness of breath, cough, anxiety. They might lose consciousness. It just depends on the severity of it. They might become cyanotic depending on how low their oxygen levels drop. And again, we could, in theory, I mean, it's not something that we have to be paranoid about. It's not something that happens like all the time. But in theory, we could do this with an acupuncture needle if we go through the lung. So that's the reason when we're needling over the lungs, we always go oblique with our needling. We don't go straight in. All right. Then we have pleurisy, also known as pleuritis, and this just means inflammation of the pleura or inflammation of the pleural membrane. So this could be due to trauma. It's possible it could be due to an infection. And typically, the main thing here is it causes sharp chest pain upon inhalation. You can imagine if the membrane surrounding the lung is inflamed, And inflammation typically causes pain. When you inhale and the lungs, expand, that's going to put tension on the pleural membrane, and it's going to be painful if it's already inflamed. So we call that pleurisy, or it could be called pleuritis. Make sure you know it could go by either name. Because pleuritis, that's it. It is what it sounds like, right? Itis, we know, means inflammation, and the pleur refers to the pleura. But if they use the term pleurisy, then it's a little less obvious. It's a little less obvious that what it means is inflammation of the pleura. Then we have a pulmonary embolism. And remember, one of the major risk factors for a pulmonary embolism is a deep vein thrombosis. So somebody can develop a blood clot in the deep veins of the body, most commonly the veins that are deep behind the leg. So the veins that are deep to the gastrocnemius and the hamstrings, particularly if somebody's more sedentary, they've been sitting for long periods of time, they were on a long flight, where they sat for 12 hours or something like that. There is a possibility that that could increase the risk for, well, it does increase the risk. And there's a possibility that a blood clot could develop, a thrombosis in those deep veins. Now, a deep vein thrombosis, this is a mistake that some people make, so be a little bit careful about. A deep vein thrombosis is not a pulmonary embolism. A deep vein thrombosis is just a deep vein thrombosis, a blood clot in the deep veins of the leg. But there is the potential that if that clot dislodges, it could travel up the veins into the right atrium of the heart, because it'll go up the veins into the inferior vena cava, into the right atrium of the heart, down to the right ventricle, and then get pumped out to the lungs. And then it gets stuck in the smaller vessels within the lungs. And then when that happens, we would say the person has a pulmonary embolism. And that clot ends up blocking blood flow to an area of one of the lungs. And depending on how large of an area, it could be, the symptoms could be anywhere from just some chest pain, a little bit of shortness of breath, to like, losing consciousness and death if severe enough. Right. So make sure you know that deep vein thrombosis is a risk factor for a pulmonary embolism, but make sure that you don't use the terms interchangeably. If the clot is still in the legs, that's not a pulmonary embolism. And if the clot has traveled to the lungs, it's no longer a deep vein thrombosis. It's now a pulmonary embolism. It's just one can potentially lead to the other. All right. And this is a reason that if you have any reason to suspect a deep vein thrombosis, the area would be contraindicated for massage, because you could potentially dislodge it. You can contribute to dislodging it if you give a massage over the area. All right. So just something to be aware of and cautious about. So if they ever gave you a question where like they told you somebody who had these risk factors, like they were on a long flight, they flew to Australia, they were sitting down for, 15 hours or whatever the flight is. Ever since, they've kind of noticed that they've got this little pain in the back of their leg, and they're coming to you because they want you to take care of that. Something like that should be a red flag, that kind of scenario, like, oh, this could be a deep vein thrombosis. And you have to know like that you shouldn't massage that. And the reason you don't want to massage it is because you could contribute to dislodging it, and then that could create a pulmonary embolism. And then lastly, you want to know COPD, chronic obstructive pulmonary disease. This includes two disorders, emphysema and chronic bronchitis. Both of these are typically caused by years and years of smoking and are irreversible. If a person stops smoking, they could prevent it from getting worse, but they can't undo the damage that's already been done. And the basic difference between the two, you could think E for emphysema and E for elasticity, because the key thing with emphysema is the years and years of smoking triggers inflammation in the respiratory tract and in the alveoli. And over time, that damages the elastic fibers in the alveoli. And what happens is then when you inhale, the lungs expand, including, those alveoli within the lungs. They expand to accommodate the air and they can't recoil. If they lose their elasticity, they don't recoil. So the air just gets trapped in there. Because without that recoil, there's really nothing to push the air out. So old air essentially gets trapped in the alveoli, and if old air is trapped in there, you can't get the new air in effectively. So the person has to put a lot of effort into exhaling. They usually have to like lean forward, compress their chest and abdomen, and really like force it out. And then they could get some new air in. And chronic bronchitis is kind of what it sounds like. It's inflammation of the bronchi that leads to swelling of those bronchi, mucus accumulation, and all of that accumulates over time and it leads to resistance to airflow. So it's difficult to get air in and out. The reason these two get lumped together under the umbrella of COPD is because most people that develop these conditions after a history of many years of smoking, they often have overlapping features of both. They very often don't just have one or the other. They've kind of got overlapping features of both, so they've kind of got lumped together under this COPD umbrella. All right. So that's some key things for the respiratory system to focus on. Now we'll get to the nervous system. And the nervous system, this will include some things from AP3. Wait, no, AP2, sorry, from AP2. So it will include some basic anatomy of the nervous system and will also connect it to O and E1. Because remember, AP2 and O and E1, there's a lot of overlap. O and E1, you're like testing the cranial nerves. You learn what the cranial nerves do in AP2. So there's a lot of overlap there. So we'll include all of this together. So first off, just some basic anatomy stuff you want to know. You want to make sure you know the difference between a neuron and a nerve. That's something that a lot of people use interchangeably. A lot of people make that mistake of thinking they're the same thing. Make sure you know that a neuron is the cell that makes up the nervous system. There's trillions of neurons, that make up your nervous system. The neuron is the cell, the functional unit that conducts action potentials and communicates and stores memories and all the many things we think of the nervous system as doing. It's the neuron that does all that. And the neuron, remember, it's a cell that has a cell body, dendrites. Every neuron usually has multiple dendrites, which are the receptive part of the neuron. They're receiving signals from other areas. So, the dendrites respond to, things like temperature changes and pressure and pain signals. That's the receptive part. And then every neuron has one axon. And those axons, in some cases could be very long. Like axons that make up the sciatic nerve start in the low back and go all the way down to the foot. So axons can be very long, but every neuron has just one axon. And the axons send signals away. So the dendrites are the more receptive part. The axons are firing what we call action potentials, which another term for action potential is a nerve impulse. They're firing those nerve impulses and sending a signal to somewhere else, to something on the receiving side that responds to those signals. So for example, a motor neuron can send an action potential down an axon, release acetylcholine, and that's what then tells the muscle to contract. So in other words, a neuron is a name of a cell that carries out most of the processes of the nervous system. A nerve, on the other hand, is actually just a bundle of axons. So the nerve is not a name of a cell. A nerve is a bundle of axons from many different neurons in the peripheral nervous system. So, like the sciatic nerve, the radial nerve, the facial nerve, and so on, the femoral nerve, the trigeminal nerve. All of those are bundles of many, many axons from many neurons, all bundled together in the peripheral nervous system. That is a nerve. Then you want to make sure you know what your neuroglial cells are. So, first, make sure you just know them collectively, that neuroglial cells are the supporting cells in the nervous system. Like the neuroglial cells don't fire action potentials, they don't form memories or help with intellect and, allow for communication. The neurons do all that. The neuroglial cells, though, are basically cells that support the neurons. They do things like create the blood brain barrier, which protects the neurons. They nourish the neurons. So they selectively feed the neurons. That's part of the barrier. They receive from the interstitial fluid and then they secrete nutrients to the neurons. They selectively feed them, nourish them. And there's also immunological benefits. They phagocytize foreign invaders, remove debris. So essentially, they help facilitate the functioning of the neurons. So you want to just kind of know collectively what neuroglial cells are. You want to recognize the names of the examples: astrocytes, Schwann cells, oligodendrocytes, ependymal cells, microglia, satellite cells. Recognize those names as being examples of neuroglial cells. And then a couple of them have some standout functions you want to know. So you want to know like astrocytes form the blood brain barrier, Schwann cells make myelin in the peripheral nervous system, oligodendrocytes do the same in the central nervous system. Remember, myelin is really critical for insulating axons, so action potentials don't short out essentially. Now on comps, just FYI, I've seen some questions that are like so general that make sure you don't overthink them. Like there are a lot of super easy questions on the comps. And sometimes people are thinking like I must be missing something because this just seems too obvious. Please don't go down that road. There's lots of questions on comps that are obvious if you know your stuff. Like in other words, I've seen questions that are as simple as where do you find astrocytes? And the answer is just the nervous system, as opposed to the liver, or the digestive system. It's the nervous system. That's it. It's that easy. Not to say every question is that straightforward, but like there are questions that are just like, you study details like, oh, it forms the blood brain barrier. And then the question is just like, it's in the nervous system. You never know. Some questions are a little more big picture, some are more specific. Then we've got parts of the brain. So remember, you've got the two cerebral hemispheres, collectively referred to as the cerebrum. That's where conscious mind takes place, specifically the cerebral cortex. That's where we have conscious minds, memories, where we initiate muscle actions, all that kind of stuff. There's the diencephalon, which is basically the core of the cerebrum. And that contains a bunch of structures that you're probably familiar with: the hypothalamus, the thalamus, the pituitary, pineal gland. You want to just know that essentially the diencephalon's the core of the cerebrum. Those structures that we just listed are in the diencephalon. There's not really like a specific function of the diencephalon because like all these structures do different things. And most of these structures we mention when we talk about the endocrine system, which we'll talk about that next time. Then there's the cerebellum, and the cerebellum is located just inferior to the occipital lobe back here. Make sure that you don't confuse cerebellum with cerebrum. They are different. You want to make sure that you don't blend them. Some people do. And the simplest way to think of the cerebellum is where your muscle memory essentially resides. we use the expression muscle memory, like, you get good at doing some kind of skilled activity. And when you first start playing tennis, for example, you might have to really think about like exactly how to swing the racket, exactly how to like time your shot. But when you get good, you eventually get to the point where you don't even have to think about it. You just kind of automatic and you hit it. And the reason is those programs are stored in the cerebellum. So even though we call it muscle memory, it's not really literally the case that the muscle has memory. It's more like the cerebellum stores the programs for how to do certain skilled activity. So once you finally figure it out, you kind of store like, all right, this is how we do it. This is the program. And you just think to yourself consciously, okay, I want to hit that ball with the tennis racket. And you send a signal to your cerebellum and it recruits the program of, like, oh, I've seen this before. This ball's coming at me at a certain angle. I want to hit it and I want to hit it in this direction. So I'm going to recruit the hit the ball in that direction program. And it sort of from there initiates action potentials in a certain order that cause your muscles to contract with a certain rhythm. So think of that as muscle memory. So the word coordination tends to come up a lot when we talk about the cerebellum. And of course, in order to do that, the cerebellum also has to take into account equilibrium and proprioception. So it's also kind of receiving signals about equilibrium because you don't want to like fall over or something when you move your body. You want to make sure that you're staying upright and the cerebellum is taking into account, not moving your muscles in such a way that you fall over. And to do that, it also has to take into account like where your body parts are. Otherwise you might like trip over your own 2 feet. So the cerebellum has to be aware of like, okay, my right foot's here, my left foot is there. So the cerebellum is always taking in input regarding equilibrium, proprioception, the awareness of where our body parts are, and utilizes that information as part of carrying out these programs that we're talking about. Now, again, comps is going to be very straightforward. It's not about having to like write an essay about that. So you want to make sure you know like certain word association, that equilibrium, proprioception, coordination, muscle memory, like that all goes with cerebellum. And then we have the brainstem. And the brainstem essentially will connect the cerebrum to the spinal cord, but the brainstem itself is considered to be part of the brain. And remember, there's three sections of the brainstem in order from north to south is midbrain, pons, medulla oblongata. You want to know those three sections and in that order. And remember, the key thing for the brainstem is that it regulates organ activity. Essentially, most of your autonomic neurons that regulate things like respiratory rhythm, heart rhythm, blood pressure, they all originate from the brainstem. So the brainstem is really critical. Brainstem function is really critical for regulating things like your heart rate, your respiratory rate, and so on. So in other words, there's clusters of neurons in the brainstem that we call like the respiratory center, the cardiac center, et cetera, because that's where we're initiating the firing of the autonomic nerves that regulate those things. Then we've got Broca's area, Wernicke's area. Those aren't really like their own regions of the brain. They're part of the cerebral cortex. They're within the cerebral cortex, but these definitely come up on comps. These are two areas that relate to language, and you want to just make sure you know the difference between the two. They both relate to language, but Broca's area is more about speech production. In other words, output, language output, coming up with the words you want to say and saying those. That's Broca's area that's going to control that. Wernicke's area, on the other hand, it's the opposite. Wernicke's area is more about understanding written and spoken language. So understanding what you're reading, understanding what somebody's saying to you. Basically, if somebody has a stroke, for example, and it damages Broca's area, they're going to have what's called expressive aphasia. They're going to have expressive aphasia. They won't be able to come up with the words they want to say. So, like, either nothing will come out or they'll say words that don't make any sense, like kind of gibberish will come out. Whereas if somebody has a stroke, for example, or head injury that damages Wernicke's area, they will be able to talk, but they won't understand what you're saying. Like what you're saying, it's like you might as well speak a different language because they can't process it. So that's what they call fluent aphasia because the person is able to speak, but they're not understanding language. So again, just make sure you know which one is which. Then we have the autonomic division of the nervous system, the autonomic nervous system. And remember, we can divide that into two categories, parasympathetic and parasympathetic and sympathetic. And imagine there's a line here creating two columns. It's not perfectly aligned, but parasympathetic on this side, sympathetic on this side. You want to make sure you know which does what to various organs and tissues of the body. So you could get questions about, like sympathetic stimulus does which of the following, parasympathetic stimulus does which of the following. And remember, they always oppose each other. They always work in opposition to each other. So if you know one side, you know the other. Because if one side causes constriction, for example, of a particular structure, the other side's going to cause dilation. If one side speeds up the heart, the other is going to slow it down, that kind of thing. So let's go through some key structures. If you're talking about the pupils of the eyes, parasympathetic will cause constriction, sympathetic will cause a dilation. Now, the way to think about that, the reason why is remember, parasympathetic we associate with like rest and digest activities, maintenance, maintenance of the organism, the tissues, calmness, restfulness. Sympathetic, we tend to associate more with fight or flight. We have to spring into action. There's an emergency. So, like, constricted pupils are all about like close up vision. So, like, I'm relaxed, I'm reading, I only really care about what's immediately around me. Dilated pupils are more about distance vision. So, that's like more on alert. Like, is there a predator out there looking at me? Where can I run to? What's going on? Like, you're more on high alert. Bronchi, parasympathetic constricts them because if you're in a restful state, you don't really need as much oxygen. So we could prioritize filtering the air and warming the air a little bit better with more constricted bronchi. But if you're in like fight or flight, now you need as much oxygen as possible. So we dilate the bronchi. That goes into what we were talking about earlier with bronchodilators having sympathetic stimulants within them when we were mentioning that for pharmacology. Heart rate, same kind of thing. Like if we're in a period of rest, parasympathetic would be firing more and we'd have a decreased heart rate. But if emergency comes up, sympathetic fires, we get increased heart rate. We need to circulate more blood and we got to run off. Blood vessel diameter, and therefore by extension, blood pressure. Parasympathetic stimulus dilates the blood vessels. That would lower blood pressure because there's more room in the vessels now. Sympathetic constricts blood vessels. That would raise the blood pressure because now the blood's in a smaller, tighter space. And then, of course, it's right in the description we always use. If you remember the parasympathetic, we associate with rest and digest processes. Parasympathetic stimulation promotes things like peristalsis, bowel movements, urination, etc. And sympathetic stimulus suppresses those things. The idea is right now we have an emergency. We need to devote all our energy, we need to devote our blood flow to our skeletal muscles so we could run. Digesting that cheeseburger, that could wait a half an hour. So sympathetic would suppress digestive processes and such. Now, one thing to be a little bit careful of is make sure when you get asked a question about this that you really are looking at the structure that it's specifying. Is it asking about the bronchi or is it asking about the blood vessels? Because that changes the answer. Notice parasympathetic stimulus constricts bronchi, but it dilates blood vessels. They're two different structures, different effects. So make sure when you study, you keep all that in mind. So many things look obvious in the moment when you're sitting in class and somebody's telling you, like, yeah, okay, that makes sense. But I've had it happen so many times, like where after an exam, like somebody doesn't pass and I'm going over it with them and trying to see where they went wrong. And a topic like this comes up, and the student will say something to me that's so overgeneralized that you see like why they struggled. Like I'll ask them to explain their thinking on a question having to do with this, and they'll say like, "Oh, I just kind of always think of like parasympathetic as opening everything up." And like literally, I'm quoting something that I've heard people say before, and I'm like, "What does that mean? Open everything up?" I mean, that's very not specific. So like that's how people get questions like that wrong because they study it this sort of overly broad way and it doesn't really answer a lot of the questions that come up. Like, and when you even ask the student, like, well, what does that mean? Open everything up. Like, oh, like just open, like, okay. So make sure you are studying this like a little more specifically than that, right? Then remember there's the meninges and the cerebrospinal fluid. The meninges, remember, are the membranes that wrap around the brain and the spinal cord, and they provide protection, cushioning, etc. And there's three layers to the meninges, and the layers do sometimes come up. So the layer that's right on the brain spinal cord itself is called the pia mater. Then the middle layer is the arachnoid mater, and then the more superficial outermost layer is the dura mater. And there's this little acronym PAD to remember the three layers. And that works because literally this is padding, right? This is padding around the brain and the spinal cord. Now, under the umbrella of what I mentioned a little bit earlier today, if there's something that I put in the notes, like don't gloss over it, like make sure that you do your best to try and remember, anything that's here. Because like something like this, it might be easy to just gloss over. Okay, dura mater's thick, strong, blah, blah, blah. But I have literally seen questions come up where it says like, which of the following is considered to be is known for being thick and tough? Something like that. Thick and tough and strong. And the answer is the dura mater. And it's right in the name. Dura isn't durable. It's very durable. It's thick. It's very tough. It's very dense. It's kind of like a known key detail. Like surgeons know that like having to cut through the dura mater is difficult. So it's a thing that does come up on testing. So make sure you know the layers of the meninges. Make sure you know just in general what the meninges are, the three layers in order. Remember that there's cerebral spinal fluid, and that's formed in these structures called the choroid plexus or plexuses. And they leak fluid into the ventricles of the brain. And the ventricles are just these hollow areas in the brain that essentially receive the cerebral spinal fluid. And then from there, the fluid diffuses into the subarachnoid space. That's the space between the arachnoid mater and the pia mater. So subarachnoid, meaning beneath the arachnoid. And that provides an additional layer of cushioning and protection. And also, there's nutrients in the cerebral spinal fluid. So it'll nourish some of the meninges and everything. And we're constantly making new fluid and we're reabsorbing the old. So arachnoid villi, there's these little villi that are basically little venules in the arachnoid area, and they're going to reabsorb that fluid. And then it'll go from there into veins and back into general circulation. Then something that's really easy, yet there's a key thing that can be easy to forget that people make mistakes on sometimes. So remember, when it comes to peripheral nerves, remember we have, well, first of all, remember we have the central nervous system, which is the brain and the spinal cord. And then we have nerves that come off of that and go out into the periphery. Now, some of them branch into other nerves, like other peripheral nerves, but the ones that come off the brain, we call cranial nerves. And we'll go into those in a minute. Those are the ones that have names and numbers. The ones that come directly off the spinal cord are called spinal nerves. And then a lot of the spinal nerves will then break up into multiple branches, and then they feed into, what we might call the radial nerve and the ulnar nerve and various others. But the first branch off of the spinal cord is referred to as the spinal nerve. And they're named for the vertebral level. So, in other words, they're exiting in between vertebra and they're named for the vertebra that they exit between. But here's where the little like tricky thing comes in. Are they named for the vertebra above it, or are they named for the vertebra below it? If they're exiting in between vertebra, which vertebra are they named after? And unfortunately, it's a little bit nuanced. It's sort of like in this area, they're named this way, in that area, they're named that way. So in the cervical spine, the nerve is named for the vertebra below it. So I gave you this example here, like C3, if it exits between C3 and C4, it would be called the C4 spinal nerve. In other words, the nerve is named for the vertebra below it. It's exiting in between C3 and C4. It's called the C4 nerve. But here's the problem. Here's why the rule changes. There's one extra nerve relative to the number of vertebrae. And in terms of the labeling, they label that nerve in the cervical area here. So the nerve between C7 and T1, rather than calling it the T1 nerve, it's called the C8 nerve. Probably would have been easier if they just labeled the extra nerve at the bottom, but they decided to label this one the C8 nerve that exits between C7 and T1. And that therefore throws off the numbering. So now, as we go into the thoracic and lumbar spine, notice in the thoracic and lumbar area, the nerve is named for the vertebra above. So notice the nerve that exits between T3 and T4 is named T3. It's named for the vertebra above it. The one that exited between C3 and C4 was called C4. It was named for the vertebra below it. And that's because this extra nerve, the C8 nerve, throws off the numbering. And that's what makes it something that could trick you. So you have to do your best to remember this rule. And as long as you remember the general rule and you remember this C8 nerve, you shouldn't have any problem. It should be an easy question, but you have to remember that rule. Otherwise, you kind of have a 50-50. It's always going to be named for either the vertebra above it or the vertebra below it, with the exception of C8 here, which is a little bit of a weird one. So most spinal nerves, you'd have a 50-50 shot. But rather than having it be 50-50, just remember the rule. Remember C8 between C7 and T1, and you should be able to answer any questions that come up. Right. Okay. Now let's do the cranial nerves. The cranial nerves are nerves that come directly off the brain, mostly the brain stem. And these always have a name and a number. And you want to make sure you know both, because on the test, they can call it the olfactory nerve or they can call it cranial nerve 1. So you want to make sure you know it both by both names. All right. Now, since at this point you've had O and E1, they could ask you, what's the name and number of the nerve? What does that nerve do? And then they can also ask you, like from O and E class, how do you test this nerve? Like, how do you test the functioning of this nerve? What would be a sign of this nerve not working? Where first year comps, it was more just what does it do? They didn't necessarily ask about the testing part. But, I mean, as long as you know what the nerve does, I mean, the testing part's pretty straightforward. You're just testing that that function works. So, cranial nerve one, the olfactory nerve, sense of smell. That's it. So, how do we test it in ONE1? You have the patient close their eyes, cover one nostril. You put something familiar under their open nostril, and you have them identify, oh, that's coffee. Okay, do the other side. Oh, that's peppermint. Okay, well, cranial nerve one must be working then, because cranial nerve one transmits the sense of smell from the nasal cavity up to the brain. So if it wasn't working, they wouldn't be able to smell. They wouldn't be able to smell that. They wouldn't be able to identify, oh, I don't smell anything. Then cranial nerve two, the optic nerve, that's sense of vision. So light goes through the pupil, it gets focused on the retina. The retina is the photoreceptor for vision. So when light hits the retina, that'll trigger an action potential along cranial nerve 2 to the occipital lobe. And that's where we'll consciously, create an image essentially. And that's vision. We'll see what's out there. So cranial nerve 2 is easy to test because it's basically, can you see? I mean, can you see? Then cranial nerve 2 must be working. Now, the test that you learned in class is this thing with the fingers, right? Where essentially what you're testing is their visual field. So not just like, can you see? Yes, okay. No, you check like their visual field to make sure they have a full view in front of them. So that's where you want to see like, is it about equivalent on each side? Like one side can they see your fingers way out here, and the other side they don't see your fingers till you're right in front of them. Then that might show they have an impaired visual field. Maybe something's wrong with their retina or part of their cranial nerve. So that was the test that you did for that, and it's just pure sense of vision. Then we have three cranial nerves that move the eyeball, and they move it in different directions. So I go a little out of order here because I want to group the ones that all move the eyeball. So cranial nerve 6, the abducens nerve, it just simply moves the eyeball in a lateral direction. That's it. So if they can't move one of their eyeballs in a lateral direction, that indicates there's some kind of cranial nerve 6 or abducens nerve issue. The trochlear nerve moves the eyeball in a downward and inward direction, like that combined direction. Straight downward would just be cranial nerve 3, but it's like a downward and inward direction. So like inferior medial, like cross-eyed towards the tip of your nose. That would be cranial nerve 4. So if they can't move the eyes in that kind of direction, that would be cranial nerve 4 damage or something wrong with it. Ocular motor is everything else. So every other direction other than what we said for 6 and 4, so looking straight up for example, that's the ocular motor nerve, cranial nerve 3. And cranial nerve 3, though, also constricts the pupil, also raises the eyelid. So if somebody had a cranial nerve 3 problem, they might have trouble moving the eyeball in certain directions, but they might also have like a droopy eyelid, what we call ptosis. You might notice that the pupil is overly dilated compared to the other side because cranial nerve 3 causes constriction of the pupil. So if it's not working, the opposite happens. And remember, you test all these together, so this would be the whole follow my pen. So don't move your head, just move your eyes. And you want to make sure they can follow the pen. You go in all directions. Make sure they follow the pen in all directions. Make sure the eyes are moving, not that they're turning their whole head. And if they're able to do that, well, then the cranial nerves must be working. If they're not able to move their eyeball in a particular direction, then you have to think, okay, well, what cranial nerve is responsible for that direction? Oh, they can't move it laterally? Okay, that's an abducens nerve problem. All right. Then we have a couple cranial nerves for the face. We've got the trigeminal nerve and the facial nerve. The key difference between the two, the trigeminal nerve is facial sensation mostly, but it does send motor signals to the muscles of mastication. So it does control the muscles for chewing, but it mostly is responsible for facial sensation, conducting the signals of feeling your face. The facial nerve is the opposite. It's mostly controlling the muscles of the face, so creating facial expression, smiling, frowning, wrinkling your forehead. But it does conduct a little bit of sensation. It conducts taste sensation from the anterior two-thirds of the tongue. So it does conduct a little bit of that. So in some ways, 5 and 7 are opposites of each other. Cranial nerve 5 is mostly sensation, but there's a little bit of motor control. Facial nerve is mostly motor control, a little bit of sensation. So how we test these, trigeminal nerve, you have the patient close their eyes. This is the one where you might get the cotton ball and like kind of twist it and get a little wisp of a cotton ball. And then you stroke the various regions of their face because the trigeminal nerve, you might remember, has that branch that goes to the forehead, the maxillary, the mandibular branch on each side. So you'll swipe with the cotton ball various areas of the face. The patient has their eyes closed, and then they're asked to point where they feel the cotton ball. And if they feel it all, then okay, trigeminal nerve must be working. If they don't feel something, there might be a trigeminal nerve problem. And facial nerve, since it's facial expression, facial movement, and such, facial nerve, you generally just ask them to like smile, wrinkle your forehead, just kind of ask them to do that kind of thing. And if they can do it, both sides move symmetrically, okay, then facial nerve must be working. Now, a common problem with the facial nerve is Bell's palsy. That's where the facial nerve can be paralyzed on one side, and basically they get one sided facial paralysis. So they go to smile, and like one side, everything moves, and the other side just kind of stays there paralyzed. So Bell's palsy is a cranial nerve 7 or facial nerve problem. Not always known why it's not working. It could be an infection. It could be some kind of inflammation that's compressing the nerve. It's not always clear what's causing it. Sometimes they'll just wake up one morning and it's like that. But regardless of what's causing it, that would be what we call Bell's palsy. Then we have cranial nerve 8, the vestibulocochlear nerve, sometimes also called the acoustic nerve. And this is going to conduct sensory signals for both hearing and equilibrium from the inner ear, specifically from the organ of Corti within the cochlea to the brain, where we'll then consciously interpret the sounds and everything. So if there's something wrong with the vestibulocochlear nerve, the person's going to have problems with hearing and equilibrium. One or the other or both, just depending on what exactly is wrong with the nerve. So they may have problems hearing, might have tinnitus, they might have lack of hearing, and they might have problems where they're, tilting to one side or dizzy, might have equilibrium issues. So the way we test for this, you could use, I mean, like in certain offices, they're going to have the fancy equipment with the sound canceling headphones, and you hear the beeping and the buzzing, and you hit like, oh, heard the beep. But in an office where, we don't necessarily have as fancy equipment, that's where you just do the things you learned in O&E. You could either use a tuning fork and like, hey, tell me when you hear it, see if both sides are equal, see about how far out they could hear. So you use a tuning fork, or you might recall doing the thing in O&E with your fingers. So like, tell me I'm going to do this near your ear. Tell me when you hear it. And you want to see that it's sort of like the same on both sides. And there is a condition involving the inner ear and therefore affecting the vestibulocochlear nerve called Meniere's disease. And this is an issue where there's altered pressure of the endolymph, the fluid in the inner ear. And it causes the nerve to, basically it causes the sound waves to become garbled. The sound waves that are hitting the eardrum and reverberating through the ear canal, it causes those sound waves to become garbled and it disrupts the signal. So the person gets tinnitus, hearing loss. It also can affect equilibrium. So it leads to dizziness, vertigo, nausea, vomiting. Nystagmus, you may recall, that's when the eye moves side to side. So like you have to ask the patient, like, oh, look over here at my finger, and you might notice their eye going back and forth. That can happen with Meniere's. And that happens because basically there's a mismatch between what the eyes are saying is happening with your head and what your inner ear is saying. The inner ear is saying, like, oh, we're moving back and forth, we're dizzy, we're spinning. And the eyes are going, like, no, everything's still right in front of me. And there's kind of a mismatch. And that leads to like the eyes doing some unusual movements as the brain's trying to figure this out. Then we have the glossopharyngeal nerve, cranial nerve 9. And this is another one that's a little bit mixed, where it's motor for swallowing. So when you swallow, you're sending the signals down the glossopharyngeal nerve, and that's going to control some of the muscles of the tongue and the pharynx and initiate like some of that the swallowing mechanisms. But it also is conducting taste sensation from the posterior third of the tongue. So it'll conduct taste sensation from there. And this one we usually test in combination with cranial nerve 10 and 12. So we'll mention 10 and 12 and then talk about how we test it. So 10 is the vagus nerve. Make sure you know that that's the longest cranial nerve in the body. This is the nerve that goes all the way down to the abdomen. Sends branches to the heart, to the lungs, to the digestive organs. And specifically, it's sending parasympathetic stimulus to those organs. So it does things like promote digestive function, slow the heart down, cause constriction of bronchi, all the things that we said parasympathetic stimulation does. Longest cranial nerve in the body. And make sure that you emphasize longest cranial nerve, not the longest nerve. The sciatic nerve is longer than the vagus nerve. The sciatic nerve is the longest nerve in the body, longest and thickest. Cranial nerve 10 is just the longest of the cranial nerves. And then I'll jump to cranial nerve 12 because, again, we tend to test these together. Cranial nerve 12 is the hypoglossal nerve, controls movement of the tongue. So the ability and it obviously influences your ability to speak, to swallow, to just stick your tongue out. So movement of the tongue. And we'll usually test 9, 10, and 12 together. So we'll ask the patient to swallow and we'll watch to see that their larynx appropriately, moves up and in. And, okay, they seem to be able to swallow. We'll ask them to then stick their tongue out. So you see that they stick their tongue out straight. If it deviates to one side or they can't do it, that could be an indication of something wrong with cranial nerve 12. And we'll ask them to say ah, because one of the things the vagus nerve does in terms of regulating organs is it does actually control the vocal cords. So the ability to say ah. So you test them all with all that together. It's just all in one, like swallow, stick your tongue out, say ah, and you're assessing all three of those nerves. Right. And then lastly, cranial nerve 11, the accessory nerve. That controls basically the muscles in the neck. It controls the SCM and it controls the trapezius. So the ability to like shrug your shoulders, turn your head, that's going to be influenced by cranial nerve 11. So typically what we do for this one is just put our hands on their shoulders, say, shrug your shoulders, you apply a little resistance. If they could do that without a problem, well, again, cranial nerve 11 must be working. If one side maybe doesn't go up or very weak, it could be that there's a problem with cranial nerve 11 on that side. All right. So those would be the cranial nerves there. So that should include like anatomy, physiology 2 stuff as well as some O&E stuff. And yeah, looking at the time, I was just sitting here kind of debating like, do I just kind of wrap up a couple of things? But um, this has been a pretty long one with a lot of stuff thrown in. So I think we'll just save this for next time. So next time we'll finish up O&E because I have a separate handout that has the myotomes, the dermatomes, and all that. So we will go over that next time, and we'll finish up some of this general pharmacology stuff next time. And remember, next time is a few weeks out. So I had mentioned this at the beginning of class. The next class meeting isn't until February 19th, week 7 of the term. So 3 weeks out. All right. So anyway, we will pick up there when we get back. All right. Bye, everybody.